morning.
Good morning, Your Honour.
Mr. Deacon.
Thank you. Dr. Bramley will pick up your evidence now. You've had the opportunity to sit in court while the evidence of various expert witnesses was taken. You saw the conclave. Please try and answer verbally. You remember the transcript doesn't pick up nodding. You saw the conclave of Dr. Consimbos, Dr. Curl, Dr. French giving evidence.
Yes.
You also had the opportunity to see Dr. Ibrahim giving evidence.
Yes.
And the epidemiologists, Professors Bennett and McIntyre.
Correct.
Can we go back to the commencement of the outbreak?
Yes.
11 April 2020. How is it that you became aware that a COVID positive patient, that there was a COVID positive resident at Newmarch House? How did you first become aware of that?
I can't exactly remember. My recollection, which could well be inaccurate, but somebody has told me there's been a positive patient, and generally I was on call as the infectious diseases physician over the Easter weekend. I remember it being aware of it on the 12th. I'm not sure if I was aware of it on the 11th.
Right. Your statement is, my recollection is that I learnt of the case at Newmarch on 12 April and that on being advised of the case, I attempted to call the facility.
Correct.
But you don't explain how it was that you became aware.
It would probably be either the laboratory ringing me directly or the public health unit ringing me. It would be either of those two people. Actually, the first case was not our laboratory, so it would have been public health ringing me, I think.
Right, okay. You then turned up on the morning of the 12th of April at the facility. Is that right?
Correct.
After you couldn't get through, you went there physically. That was Easter Sunday?
Easter Sunday, yep.
And what was the purpose of attending at that time?
I guess with my Dorothy Henderson experience, I was expecting that this would cause a lot of concern.
Amongst whom?
Amongst the staff at Newmarch.
Right. So it was there to provide support to staff? Was that the primary purpose?
And to information gather, to understand some details of the case or what had happened or why they had a case.
Right. Was it clear to you right from the outset that the residents at Newmarch would fall within the Nepean LHD catchment area?
But yes, clearly it's close by Nepean Hospital and it's very much in our territory.
It's only about 1.5 or 1.7 kilometres down the road, isn't it?
In fact, I walked that distance regularly.
Right.
And during the outbreak, I sometimes walked.
So when you attended on the 12th of April, was it with a view to the possibility that you would come to play a role in managing the outbreak at the home?
No, it was with a view to simply finding information.
Right. And what is the purpose of finding information? To what end?
Well, we had taken the decision as a department, if I take you back to that period of time, there was a lot of hasty planning occurring.
Hasty planning?
There was a lot of pressured planning for COVID. And each unit and department was working out their departmental policy and how they would approach that. And obviously being in the infectious diseases department, it was crucial that we had a system in place to actually deal with positive cases. And we had dealt with quite a few by that stage by admitting them to our hospital in the home program.
But does it follow, given the location of Newmarch, that there was an expectation that your department would take a role in looking after this situation?
Yes, it follows, and that was my expectation.
Right. Now, had you been to Newmarch home previously, previous to that attendance on the 12th of April?
No.
Had you ever treated any resident from Newmarch House prior to that attendance on the 12th of April?
I don't know. However, it's quite likely I would have treated some of them, most likely in a consultation role.
At Newmarch, at Nepean Hospital?
At Nepean. Oh. Many of these residents had been in and out of Nepean.
So is it the case that when you turned up on the 12th, you weren't familiar with the layout of the premises?
No, I wasn't familiar until
This was the first time you're stepping onto the site?
Yes.
Now, you've given evidence 2 days ago, it feels like 2 or 3 days ago, it feels like a long time ago now, about the swabbing and testing work that you did. And that was clearly an important aspect of your role at Newmarch House, performing those swabs, sending through those swabs to be tested, and then the process of receiving the test results, right?
Correct.
Did you see it as your role, as matters developed at Newmarch House, to direct infection prevention control procedures and measures?
In which time period?
Well, moving forward from 12 April.
Did I see it as my role to direct it? No, I saw it as my role to assist.
And to assist whom?
Whoever needed help.
And who would that be?
Well, it's likely to be the facility, the residents, the management.
You saw it as your role to assist, but not to provide directions in terms of infection prevention and control.
I object to that. The question that was asked before was direct, which has a different implication.
All right. Well, I asked you before whether you saw it as your role to direct infection prevention and control procedures and measures. You said that's not the case. You were there to advise and assist. Is that right?
Correct.
Did you give directions at any time about infection prevention and control measures at Newmarch House? When did you start giving those directions?
I think I gave those directions intermittently throughout the outbreak in a problem-solving type fashion.
Right. And
so it would not be unusual to be asked questions that had an infection control flavour to them.
yes.
And I would give my opinion.
Were people from the facility, for example, coming to you and asking you questions about the procedures that should be put in place concerning infection prevention and control? Was that occurring?
Yes, lots of things were occurring. If I could talk more generally, perhaps.
Well, perhaps if you just answer the questions for the moment. If there's something important that you want to say to complete the answer, then please do so. I don't want to cut you off.
What I'd like to say to complete the answer is I didn't have a preformed view as to what I was doing. I think I went there and things evolved.
In that first week, let's just focus on that first week, because you were there regularly during the first week. Is that right?
Yes.
Daily?
I can't remember.
And in terms of your attendances in that first week, if you did attend on days, were you there for a significant part of the day, or an hour here, an hour here, there? Can you estimate that for us?
I think both, depending on what I was doing. On the days where I was doing a round of one of the wings and swabbing, for example, I might be in PPE for an extended period of time, and I might be there for many hours.
Yes.
And then I would doff, wash, take the swabs back to the laboratory, get them running, do a swab on myself, and I may return later in the day if there were swabs that were positive coming off. I can't remember the exact day-to-day of every day I was there. There would be other days where I might have turned up, problem solved, left, come back. So it would be variable. But I think most days I was there.
In that first week, just focusing on that period for the moment, how many of these rounds, how many days did you perform these rounds through the various wings in PPE?
Sorry, everything I did was in PPE essentially.
You said that on occasion that you would don full PPE and do a round of the various wings, and that would take hours, right? I'm asking on how many days in the first week do you estimate that you did that?
I would have done it every day, I think. It was Easter, so I'm not sure about Monday. I mean, the other thing in that mix is meetings. You know, progressively there were more requests to attend meetings, and it was confused.
Just go back. Can I go back to the question I asked you before about people from the facility coming up and asking for your advice and guidance about infection prevention and control measures? You've indicated that that did occur.
Yes.
Do you remember particular individuals coming to ask you for that type of advice and guidance?
I do remember Melinda Burns, for example, on the first day when I was there.
She was the facility manager?
Correct.
Yes.
I remember Leanne Hinton. And I remember being shown through the facility and getting my head around the geography.
You also remember talking about these issues with Christine Giles?
Yes, when Christine arrived, yes.
And providing her advice and guidance on these issues.
And Cameron Elliott as well.
Right.
And David Goodhue was in the background. I never met David.
Did you say you did or didn't meet him?
I did not meet him.
You never met him physically?
No.
Did you ever see him at the home?
No.
Did you ever see a Mr. Pretorius at the home?
No.
Did you ever see Mr. Millard at the home?
Yes.
When was that?
It was the Saturday before Mother's Day.
Well, we'll have to get that date. Someone can work that out. Now, was there anyone else on the ground in this first week giving directions about infection prevention and control?
I'd have to check the date that Rob Robinson came down and helped. I did ask Rob to come and help.
That date was 25 April, you think, in respect of seeing Mr. Millard. That's the Saturday before Mother's Day, that's what I'm told. Does that sound right to you?
Saturday before Mother's Day, I think it would have been the 9th of May.
Thank you. 9th of May. I've just received another note. I think you're right about that. Okay. Yeah, I think so. We can take that note back. Sorry, Doctor. Just coming back to this issue about people giving direction, you mentioned Mr. Robinson.
Yes.
He was someone based at Nepean Hospital.
Yes.
He was a nurse with a background in infection control.
More than a nurse. Rob has many years' experience and is a
CNC.
CNC, yeah.
Clinical nurse consultant. I didn't mean to his position. He has an area of expertise in infection prevention and control.
And Rob and I have worked together for many years.
You recall him being present during that first week?
I think so, but I'm not sure. I'd have to check records.
What sort of matters did you advise in terms of infection prevention and control? Can we go to the specifics of the advice you're giving?
Yeah, so I advised about masks. I advised about infection control, if I may elaborate. Infection control, in my mind, depends where you put the red line. And the experience at Dorothy Henderson was that we had the red line at the front door. And that was for a reason. We had wandering patients. And my recollection is we did the same thing at Newmarch right from the outset. We put the red line at the front door. And that's where you put your PPE on initially. That plan was revised a lot of times during the course of the outbreak, but that was the initial gambit.
All right. First or main line of defence, the front entry.
The front entry beyond the control room. So the control room is right at the front door, and the line was behind the control room. So people could still come in and out of the control room. Managers, senior people, and that was a that was on the green side of the red line, if you understand my terminology.
Yes, I do. Were staff who worked within the facility going into that control room from time to time?
Probably. Oh, undoubtedly they would have been from time to time.
Just coming back to the question I asked you, which was specific pieces of advice that you gave. You've outlined there a principle, but I want to know what advice you're giving people about infection prevention and control.
I was asked about masks, and my advice was, the specific question I was asked about was, should we be wearing N95 masks?
And your advice was what?
To wear N95 masks.
Were there N95 masks available within the first week of
Yes, there were.
Outbreak?
Yes, there were. There was an issue with supply a little later, but it wasn't a critical supply issue. But I was asked the question whether the staff member attending to every patient needed an N95 mask, or whether we could narrow the process down to just using an N95 mask on the positive patients and using a surgical mask on the negative patients. And my advice was to use N95s throughout the facility if they were available. If there was a critical supply, I was happy to go to plan B of using N95s on the positives and surgicals on the negatives.
There's been evidence in this inquest about an extraordinary level of N95 mask usage throughout the outbreak. I think in the early phases there was evidence that there was something like 1,500 N95 masks being used per day. Does that sound right to you?
That sounds good.
Did you understand that there were temperature checks occurring at the front entrance, that red line,
Yes.
in the first week?
when I first arrived, there was temperature and vaccination checking at the front desk, and that had been established when the facility went into lockdown some weeks earlier.
Was it your understanding that that operated throughout the period, temperature checks at the front line?
Yes, absolutely. And I remember the vaccine check too, because I think initially I wasn't allowed into the facility. So I had to obtain the email from the Wentworth Falls pharmacy that had given me my flu vax before I could actually go in. So I think that was functioning when I got there.
Right. There has been evidence given, in particular by a nurse named Nurse Bestron, that temperature checks were not occurring at the front on a systematic basis. Are you aware of any of that?
I'm not
those circumstances?
But my views were that I was doing my temperature on arrival, and progressively, late April, it was pretty bloody cold. It was cold.
The temperature?
So it was cold coming in the morning, because that's how I remember that when I took my temperature, it was often...
Right, that triggers a memory that
Yes.
your temperature was taken because it was the ambient temperature at the time was cold.
Yes, but I don't know that there was a person designated to take temperatures. There was a thermometer and a table and a book to write your temperature in.
So it was a self-check system.
Yes.
Now, apart from giving advice and guidance about masks, what other particular advice and guidance did you give on the subject of infection prevention and control?
I had a big alarm bell ringing in my head about Wentworth Heights after I'd looked at the facility. And I prioritised efforts to... I thought our greatest threat was Wentworth Heights.
Because of the high dependency nature of the ward?
Once I'd been into that ward and seen the free movement of patients with quite serious dementia, and the inability to contain them within rooms, I was very, very worried about that situation.
So what was the practical advice that you're giving in respect of IPC in that context?
In that context, I prioritised testing and removal of positives from that area.
Right.
That's a very important infection control piece of advice, because the facility had single rooms with en-suites throughout. So our greatest risk of wanderers was in Wentworth Heights. And if we didn't shut down any transmission in that area, we would have potentially had 15 to 30 additional cases in that area. So I was concerned.
So there's another piece of advice given. Were there any others?
With due respect, I can't remember. I think probably, but individual pieces of advice I'm struggling to remember.
What about advice in respect of the movement of staff throughout the facility? Did you advise on those issues?
I did on numerous occasions say we needed to try and have COVID positive staff and COVID negative staff. Initially, I think that was not advice that would have been given in the first few days, because we hadn't delineated the extent of the problem. But certainly, as we went through, we looked to separate staff into looking after positives and negatives. I do remember giving advice about staff behaviours.
And can I ask you to try and remember who it was that you gave this advice to?
The control room, I would say, whoever was in there at the time.
You mentioned in a previous answer that advice started to be given a few days in because you hadn't delineated the problem yet. But why wasn't it possible to advise right from the outset that there should be a separation of staff dealing with COVID positive residents as opposed to those who hadn't tested positive?
On Easter Sunday, I think that was... on Easter Sunday, we had, I think, one resident positive, and clearly that I don't think that even needed to be stated. It was I was probably told that's what they were doing.
The successive days after the first day?
Successive days, I'm struggling to remember. I don't have specific memories about bits of advice that I gave during that period of time, but some stuff to me and a nurse in conversation would be incredibly obvious and wouldn't need to be stated. And using staff to look after positives and separating staff to look after negatives would be one of those type issues.
Let me give an example. On 14 April, there were 4 positive cases. By the 15th of April, there were 13 cases that tested positive.
So
were there separation procedures in place, to your understanding, say, by the 15th of April?
Yeah, so one of the advantages to going down there was I did look at the geography, and we had made the decision, I can't remember whether it was me or whether it had already been made before I came there, that residents would be confined to their rooms. Now, effectively, that separates positives and negatives in a very deft and simple way, and is a huge advantage in infection control.
We've moved into the area of infection prevention and control and what you're doing in respect of that. In some detail, you've given an indication of the types of matters you're advising about. Is there anything else you'd add to that list before I move on to ask about other aspects of your role?
Well, we did have the National Infection Control expert on the phone very soon in the outbreak.
Who was that?
Professor Lynn Gilbert.
Right. When you say we had her on the phone, when did that happen?
Tuesday or Wednesday, I would say, of the first week, but I'd have to be corrected.
Right. Have you ever given evidence about that before?
Not as far as I know. When I say on the phone, she was with Michael Lai.
Were you on that phone call?
Yes.
And are you saying that Professor Gilbert was giving advice about infection control measures?
Well, I think she was listening to what I was saying, but I assumed we were working in collaboration.
Did Professor Gilbert ever come to Newmarch?
No.
During the course of the outbreak?
No.
She'd been involved in respect of Dorothy Henderson.
She'd written a report, I think.
She'd reported on the outbreak.
She'd been asked to write a report, I believe.
Do you recall how long this telephone call went for?
It was multiple telephone calls, is my recollection. She was frequently on a teleconference with myself and Mr. Lai and other people. I think in my statement I talk about this as the Commonwealth teleconference group.
Right. Paragraph 105 of your Royal Commission statement, you say this: I participated in a Commonwealth-chaired group via teleconference. I've described this committee in greater detail below. Professor Lynn Gilbert participated in this group as an expert voice to guide discussion about infection strategy and infection control. That's the part of your evidence you're referring to?
Yes.
Were those meetings different from the interdepartmental meetings that were going on a daily basis, sometimes referred to as the leadership group?
To be honest, there were so many meetings. I don't know what the interdepartmental meeting is.
You refer in your statement, this is your Royal Commission statement, paragraph 114, to a state-based Newmarch group.
Okay, can you read out the...
Yes. Initially, this group was organised and chaired by Stephanie Williams. It later became chaired by Michael Douglas, and towards the end of the outbreak was chaired by Eric Aldergower.
Yeah, no, that's a very different meeting. That's a low, in my view, a lower level meeting, but much more operational meeting, if I can put it that way.
Right. The meetings, I mean, you've gone and spoken about participants in the meeting, including Lisa Peterson from the Commonwealth Department of Health, Grant Millard, Mr. Forsman, Ms. Wunsch from the Aged Care Quality and Safety Commission, Ms. Dempsey, Baptist Care people. It doesn't sound like a low-level meeting. No,
I didn't mean that disrespectfully. I just felt that was more of a state-based meeting, perhaps, than the other Commonwealth-based meeting. Please accept my apologies if I'm not getting the terminology right. But
no need to apologise.
It was confusing.
All right, so you've got a Commonwealth-chaired group, which was a different set of meetings, chaired by Michael Lai, who's Deputy Secretary of the Commonwealth Department of Health at the time. That's what you say in your statement.
Yes. And I remember that the Michael Lai meeting, Lynn was very supportive and helpful in that meeting.
Now, can I again come back to this issue of the nature of your role? You've explained that it evolved as the circumstances developed, right? Did it become part of your role to provide medical care to residents or patients?
Yes. However, that also was a rapidly evolving situation.
When was it that you commenced providing medical care? When was the first occasion that occurred?
Well, I would probably say the first day that I went there, and I can't remember if it was that day or a few days later, but I would have seen the first patient for a variety of reasons.
But did that aspect of your role continue throughout, providing medical care?
That aspect evolved, and in many ways that evolution could be described as me delegating that role to the two teams that we had decided to use as part of the outbreak.
And who were those two teams?
So that was HIF and VAX.
Right, so is your evidence that in the initial stages you were there providing medical care as and when required, but as matters progressed and an approach was implemented, that function was increasingly delegated to the HIF and the VAX teams?
Yes, and more importantly, the VAX team, and I can delineate the reasons for that if you'd like me to.
Well, I just want to ask about your role at the moment before we go into the model.
Sure.
Because we've got quite a bit of territory to cover. Sure. Was it part of your role to provide medical advice to other practitioners who were involved in providing medical care.
Yes.
Right? Did that function continue throughout?
Yes.
And did that include providing medical advice to the VAX team or members of the VAX team?
Yes.
And what about members of the HIF team?
Yes, although it became apparent that the HIF team were not able to get information as efficiently as the VAX team.
Because of their difficulties experiencing getting in contact with the facility? Is that the reason?
Yes.
Difficulties in actually obtaining information about patients?
And no access to the electronic system, the iCare system, or the electronic notes from Newmarch.
From a certain point in time? Or throughout?
Well, it was even worse when it was on paper because nobody had access to the paper records.
But are you indicating that they had difficulty getting access to the electronic records at an earlier point in time when the e-record system was still being used?
Yes.
Did you discuss with members of the HIF team this problem that they were encountering? Were you aware of it at the time? That's what I'm asking.
I was aware of elements of it, but I've become aware of a lot more, certainly listening to, the Royal Commission and this process.
Try and separate out what you've learned since. I know it's hard. What you knew at the time. You had a position of leadership in the HIF team, didn't you?
I did, but there was a lot of concern about coming and going back to the HIF team. So what has become apparent to me that what was in my head wasn't in everyone else's head.
Right. What was in your head and what was in everyone else's head?
What was in my head was we should smash HIF and VAX together and have a joint control room at the hospital and a joint control room down at Newmarch, and we should mirror each other and share information.
Yep.
That plan spectacularly failed.
When did it become apparent to you that that plan spectacularly failed?
Well, the 20th of April was my crisis day.
Yes.
And I think I've detailed that in my summary.
Yeah, we'll come to that terrible day in due course. So by that time, it was clear to you, was it, that the two arms of the clinical approach weren't integrated effectively?
Yes, and we didn't have a shared understanding throughout all the elements, and that I think it was a systems issue rather than an individual's issue. It's hard to implement things quickly, and it's one of the faults in my thinking at the time.
The fault in your thinking, that's a concession?
Yes.
A frank concession?
Yes.
Was it part of your role to make decisions about the escalation of treatment of deteriorating patients?
Yes.
Was that a role that you undertook throughout your involvement in the Newmarch outbreak? Or was that a role that was affected at certain points in time?
I think I only really had that role until we got VAX up and running and doing, the clinical reviews that I felt needed to be done. The prioritising of VAX was around trying to talk to the individuals and find out what they made of this illness and what they wanted from their care.
So is it your evidence that once VAX became involved, that effectively it was VAX's role to make decisions about the escalation of treatment of deteriorating patients?
Yes, I think there was an evolution from me being the first person on the ground to there being more people on the ground as time went by, and I reduced my clinical input, and I obviously had other roles that I was doing which VAX weren't able to do. So we divided work somewhat.
Right, but does it follow from that evidence that there wasn't a clear break from which you had no further involvement about decisions concerning the escalation of treatment of deteriorating patients, that you continued to perform that role on occasion, but with VAX doing most of the work on that front? Is that the case?
I guess I would phrase it that there were situations where issues would get elevated to me, and I might express an opinion.
You mentioned that there was a date when work was, you mentioned that there was a time when work was divided between you. When did that occur in your mind?
In my mind, I saw Dr. Kakat and Hayley Carpin there very, very early on. And in discussions with Anita Sharma, I would say that's the first week we were prioritising trying to individualise plans that week.
How often do you say that you saw Dr. Kakat present in the first week?
The first week in particular, I think he would be there most days. There was crossover because I was also leaving the facility and coming back, but I think he would have been there most days in the first week.
What was Dr. Kakat doing there when you saw him? Was he in a control room area in the foyer? Was he doing rounds with patients? What did you observe?
So the foyer's different to the control room, and Dr. Kakat and Dr. Sharma and Hayley tended to base themselves out of the foyer. But I did see Dr. Kakat and Hayley Carpin in PPE in the ward space as well.
Would you expect that when Dr. Kakat saw patients that he would record his attendance in the medical notes?
Yes.
The medical notes indicate that he saw patients on the 17th of April, the 22nd of April, the 23rd of April. He actually saw patients on those days. Excuse me for one moment. 17, 22, 23 April. Just with that piece of information in mind, are you confident that you saw Dr. Kakat seeing patients in the first week?
My memory would have been that it was the very first working day, but maybe my memory is, I can't remember.
All right. Sorry, did you say she saw it twice throughout the whole period? And just while we're on the subject of recording attendances in progress notes or consultations with patients, if you saw patients in a medical capacity, would you have recorded your attendance in the medical notes?
Generally, I tend to ask people to scribe for me, and I would have asked people to record it, but I wasn't taking notes down at Newmarch.
An analysis has been done, as you'd imagine, of when particular practitioners are named in the recorded medical notes that we have. There's an indication on the 20th of April that you attended Ms. Maria James, Margaret Brocklehurst, and Leonie Corrigan. There's a note then on the 21st of April in terms of Ms. Rendoff, 2nd of May in relation to Anne Fay, 5 May in relation to Olive Grego, and you're also mentioned in the notes on the 14th of May in relation to Alice Bacon. That's a different type of note. We'll come to that later. So I'll just give you those dates again. There's a lot of information to deluge you with. 20 April, your name comes up next to 3 patients. 21 April, 2 May, 5 May, 14 May. Is that a reliable indication of the frequency with which you were seeing patients during the outbreak?
I object to that unless it clarifies whether or not, which class of patients is included in that analysis.
I'm limiting this analysis to the COVID positive patients who are the subject of this inquest, in other words, those who passed away. Is that a reliable indication of the frequency with which you're seeing that particular cohort of patients?
So can I just clarify, a lot of the patients I looked after, a lot of the residents I looked after survived, and we are not including those in this question?
No, we're not.
Okay. Is it reliable information? I will take it as read because I can't refute it. I don't know.
But not asking you to refute it. Does it accord with your sense of how often you're seeing this particular group of patients, the 19
yes,
who are the subject of these inquests? It's
probably accurate, and some of those encounters I can remember, and others perhaps not. It's a confusing time.
Just coming back to that issue about whether it was part of your role to make decisions about the escalation of treatment of deteriorating patients, I've asked you a series of questions about that. Who did you understand? And you might need to variegate your answer according to different time periods, but who did you understand was the lead clinician in respect of the management and treatment of the COVID positive patients at Newmarch House?
Look, I will own that responsibility. I think I was certainly public with the families that I was the lead clinician responsible, and I do accept responsibility. Can I just clarify, for the Nepean team?
For the Nepean team?
Yeah.
And what does the Nepean team mean in this context?
It means HITH and VAX. And
VAX. That's what I wanted to understand, whether you're incorporating within that, whether you're only speaking about the infectious diseases department or including HITHs and including VAX.
I think if you are in this situation and you want to lead in this situation, you need to own the responsibility, and I've never walked away from that.
Yeah. Is that for the entire time period of the outbreak?
Well, the entire time period I was there, and I'm sure we'll get to this, but the Anzac Day weekend, I was not there. And there are reasons for that. Right.
Well, that might be something to do with your military engagement.
I did go to an Anzac Day service, but it was due to an evolving situation in and around Anzac Day, so the day or two before.
You mean another outbreak type situation?
Another outbreak, and there were 3 sudden unexplained positives in the Upper Mountains and Lithgow, and one of them was a worker in Colesworth, supermarket, and we had a lot of concern that was going to be a super spreader event in the Upper Mountains. And there was a smattering of cases in Hawkesbury, I think, as well. So we had unexplained cases occurring at the end of that week in the Hawkesbury district and also in the Upper Mountains and Lithgow, one of which was an aged care worker in Boddington Nursing Home. And so I was tasked to go up there and look at that situation.
It's obviously acknowledged that you've accepted responsibility as the lead clinician. And thank you for that frank acceptance of responsibility. But can I ask this question? Did you discuss with other medical practitioners that responsibility, that position of lead clinician? Was that talked about?
No, and there's sensitivities in teams. Each team had developed their own plan and owned their own plan, and I had asked them to work together. But I think in the act of asking them to work together, I assumed that role.
Right. Just by virtue of the fact that you were making that request.
Correct.
And that request could be understood to be a direction of sorts.
Correct.
Can I take you to your statement, Royal Commission statement of paragraphs 76 to 77? I just want to ask you about this part of the statement, because this is where you set out in evidence what you understood your role was in respect of medical care. You say, in addition to swabbing patients, my role at Newmarch as part of the HIF-VAX team involved attending COVID-19 positive patients who had medical issues. Right? So when you read that sentence, it sounds like there is an acknowledgement that you're performing a role in terms of the provision of medical care to COVID positive patients.
There was another role in that situation as well, and I think it was important that I be seen to be in PPE with positive patients.
Just in terms of the comfort and reassurance that your presence would bring, is that what you're referring to there?
I think that.
And I should tell you that it has been acknowledged by a number of witnesses in this inquest that comfort and reassurance was drawn from your presence. All right, so that is acknowledged, Doctor.
Thank you. Can we move on?
You can if you wish. You were saying there was another aspect to it. Is that the aspect though?
The aspect also is, if you are asking nursing staff to go and look after COVID positive patients and you are not prepared to be at their side, then I don't think you can ask them to do that.
Right, so it's an issue of leading from the front line, as it were. Then what you go on to say in paragraph 77 is this: other than undertaking swabbing and infection control advice, I do not generally have a role in the medical care of COVID negative residents. These residents were primarily managed by the facility nursing staff in the usual way that such residents are managed, with advice from GPs. The VAX team may also, I'll just read that again, the VAX team may have also provided some outreach services via telehealth to these residents. I was not involved in this. So in that next paragraph, paragraph 77, what you seem to be indicating is that your role in terms of the provision of medical care to COVID negative patients was limited. Correct?
Correct, yeah.
That's COVID negative residents. And you go on to talk about the fact that they were being managed by nursing staff and GPs.
Yes.
Which GPs did you have in mind there?
Well, the issues of GPs was something that was very, very central to managing this. Which GPs did I have in mind? I don't know the GPs in Newmarch that well.
Right.
I do remember that I think there were probably 3 or 4 who were frequently attending.
During the outbreak?
No, frequently attending in normal times.
Yes.
And, I don't know how many of the patients belonged to each of them, but there was also the PHN playing a role, the Primary Health Network. And the Primary Health Network is a coordinating body for, I think, the 150 GPs that are in the Penrith district. And I know that we pushed hard to get GPs into the facility, COVID positive and COVID negative GPs into the facility. And the PHN did some work around that, and we eventually received some GP locums.
Right. That was quite a bit down the track.
Quite a bit down the track, unfortunately.
Unfortunately, why?
Unfortunately, because I pushed for that from a very early stage.
With whom?
With the meeting that essentially had what I think is the Commonwealth meeting, and we had PHN representation on that meeting, I think. And the PHN took on that role and took on that commitment. Unfortunately, and understandably, in a pandemic with fear and with other factors, it wasn't possible for GPs to give up their practice and come in and help in the facility.
You obviously had knowledge about the work of the Clinical Excellence Committee from your experience at Dorothy Henderson Lodge, right? And I'm not going to go over that evidence that you gave before. I've already asked you about your acknowledgement of the contribution that Kathy Dempsey made at an early stage of the Dorothy Henderson outbreak. Was contact made with Kathy Dempsey in the early part of the outbreak to see if she would be willing to come to the facility and perform a similar role at Newmarch House?
Yes.
When was that? When do you say that contact was made?
I don't know.
Was it on the 12th of April?
Oh, no, it wasn't the 12th of April.
I'm directing you at the moment to the early part, 12th, 13th, 14th of April. Was any contact made around that time?
I would say at the end of the first week.
Right. Kathy Dempsey arrived on site, I'm told, on the 1st of May. What do you recall whether there was a delay between the request and her attendance?
The initial request, Kathy is fantastic, and she's, I've worked with her, many times. Kathy was unavailable at the first approach.
Do you recall when that was, by reference to the date that I gave you, which is 1 May?
I don't recall when that was.
Is it correct to say that the likelihood in the first week is that Ms Dempsey was not contacted during that period of time?
I think that's likely, yes.
Right. Was there a reason for not contacting Ms Dempsey if you knew that it was a very salutary intervention at Dorothy Henderson Lodge that...
Yeah, and look, I would have loved to have Kathy there in the first week, and it's my fault that I didn't jump up and down and get her there. I probably could have spent time and effort pushing to get her there. I did have Rob Robinson 5 minutes down the road, and Rob is a very senior infection control nurse, and I think Kathy, in fact, said to me, what's Rob saying? You don't always need the number one in the state. You need good infection control expertise, but we had those two options.
Right. Do you remember how early Robinson came into the picture when he was there?
I can't remember.
Was it in the first week or later?
No, I would say it's later, and it would have been great to also get him there in the first week. I acknowledge that point.
We move now to focusing still on this first week, and I want to ask some questions just about the testing procedure that was going on, the swabbing, the testing for COVID. You were overseeing the testing of both residents and staff. Is that correct?
Which time period?
First week.
Oh, first week. I think overseeing and doing most.
Overseeing and doing personally most of the testing for residents and staff.
Yes.
Second week?
Second week, we would have had our HIF and Nepean nurses doing the swabbing. I did do some rounds with them of swabbing, but progressively less. And I think there were also efforts made to get other laboratories involved around that time.
You're drawing in other resources to assist in the process. Were you still overseeing the testing process?
I have responsibility for the Nepean laboratory. I wasn't overseeing the work that was being done at other laboratories.
I might be confusing matters by referring to testing. Let's go to that anterior point, which is swabbing, the actual taking of swabs, which were then provided to the labs. Were you overseeing that process in respect of residents and staff?
Yes.
You've given evidence about the difficulty of the swabbing process.
Yes.
But obviously, particularly in that first week where you were conducting the swabbing yourself, you took great efforts to try and make that process as effective as possible, I take it.
Yes, as effective as possible. The particular thing I'd like to contextualise there is Wentworth Heights. Wentworth Heights was incredibly difficult to get 100% of the residents swabbed. And I can detail the reasons, but I think I have previously.
You have. Gave evidence about that on the first day. Is it correct to say that by the 13th of April, that 6 staff and 3 residents had been tested by that stage?
I've got no idea.
And that across the board testing commenced on the 14th of April?
I can't remember.
Well, do you remember that an across-the-board test of residents was not performed on the first day that you were present at Newmarch House?
No, it wasn't.
You agree with that? Or the second day?
No.
And does it sound right to you that the 14th would have been the first day when across-the-board testing was performed?
I think we may have completed a full round by the 14th. That would sound reasonable.
Right. And was it the case that by the 14th of April that each resident had actually been swabbed? Is that?
No, I can almost definitely say no because of the Wentworth Heights situation.
So there were some within that particular cohort where you have doubts about whether they were
My
swabbed?
recollection is that within Blaxland, Lawson and Wentworth there were still unswabbed patients. And I don't think we ever did a round where we got 100% of the patients on the target ward. And the reason for that largely comes down to consent. We did have residents on each of those wards who would say no, and that's a difficult situation.
Right, so where there's evidence in this inquest that there was an across-the-board test, your evidence is that across-the-board swabbing, your evidence is that may not mean that every resident was actually swabbed.
Correct.
In terms of the test, the swabbing, what do you remember that you did on the 12th and the 13th? Just put aside the 14th for a moment, because that seems to be a day in which there was a very large swabbing exercise undertaken. What about those two preceding days, 12, 13?
I can't remember.
Do you think you swabbed some of the staff members during those first 2 days?
I think so, yes.
And how would you have selected those staff for swabbing?
It would have been opportunistic.
Just start with a handful. And in terms, if it is accurate that 3 residents had been swabbed and tested by the 13th of April again, how was it that those 3 would have come to be chosen for swabbing?
I'd have to look at the geographic map and see where they were and what. I can't remember.
Okay. This is not a criticism. It's a question that's directed to trying to understand matters. Why was it that there wasn't an attempt to do an across-the-board test, for example, on the 12th of April? In terms of residents, let's start with residents.
I think swabbing resource, we have to remember the time, April 2020, swabs became very routine later in the pandemic, but doing a swab and doing a correct swab was a skill that many nurses did not feel that they had that skill. Sorry, I've said many nurses. What I mean is often our nursing colleagues feel they need a procedure and they need to have been trained in it in order to do it, and that's good, sound practice. Many healthcare workers at that stage had not been trained to take a swab. I had been doing swabbing for some time.
Drive-throughs were running at that time, weren't they?
Drive-through were running at that time. I can't remember. There were fever clinics.
Can I suggest they were?
Yeah, okay. I'll accept that. However, staff within the facility asked if I could do some swabbing, and my answer was yes.
Right. So you encourage staff to, is that what you're saying? You encourage staff to perform swabbing procedures?
My recollection, and it's only my recollection, but my recollection when I arrived, there was confusion about swabbing. There was uncertainty that people had the skills to swab, and I was asked to swab, is my recollection.
I assume that by 12 April, it was at least known that COVID was highly transmissible.
Yes.
That the population in an aged care facility was a particularly vulnerable group.
Yes.
That an outbreak of size in a residential aged care facility could potentially be quite calamitous.
Yes.
In those circumstances, and noting what you've said in the last couple of answers about some logistical difficulties, nursing staff not being confident about the process, the difficulties of conducting the swabbing, was there an attempt made to do a more aggressive swabbing round in those early days, 12, 13 April?
I actually believe we were being aggressive, and I actually think that what we achieved with swabbing in those early days was very good, and we actually managed to identify people reasonably quickly given the size of the problem. So I don't accept criticism for the way we did swabbing. I think we did the best we possibly could.
I deliberately said to you when I started asking these questions, I'm not being critical.
And
I'm trying to understand why on the 12th or the 13th you didn't commence at that point with an across-the-board swabbing attempt.
If you look at my experience up till then, in Christmas Island, we were swabbing only the symptomatic patients.
Right.
If in Dorothy Henderson, we did not do an early, immediate swab of the entire facility. And in fact, when I went to Dorothy Henderson, I was swabbing patients on request, largely because those patients had become symptomatic. So my recollection is there was very much the debate at that stage. You just sit tight and you wait till people get symptomatic and you swab them if they're symptomatic. Now, that wasn't the approach that I took. I took the approach to systematically go in and swab aggressively.
Well, that's precisely right. And on the 14th, it appears at least there was an attempt to perform that type of systematic approach. And the question I'm asking is a simple one. If that was the approach that was going to be taken, why not start on 12 April as distinct from 14 April?
Because it was Easter Sunday.
Right. And is it just a staffing issue? There weren't people on the ground to help you?
Absolutely.
But I understood from your evidence that in this early phase, you were the one actually doing the swabbing yourself.
Yes, and I could have spent all of Easter Sunday swabbing the entire facility. I didn't. I'm sorry.
I'm not being critical. I'm making that clear to you a number of times, just understanding what happened. What about the 13th?
The 13th was Easter Monday. I can't remember what we did on the 13th.
All right. In any event, the first battery of swab tests for the residents was 14 April.
Yes.
Just turning to staff now. You've indicated that in the first day or so, there was some testing of a few staff members that tended to be, in terms of their selection, just tended to be a matter of happenstance.
I think so at that stage.
Was there ever across-the-board staff testing instituted?
I think in early May we made the decision to test every staff member every day.
Right.
And if I can point out that decision was highly criticised.
Criticised by whom, Doctor?
Essentially, it was felt that the union movement was not happy with us swabbing every staff member every day. That was the message that was relayed to me.
Was there an attempt by you at a point earlier than the date that you've just referred to in May to swab systematically across the staff?
I didn't have the resource to, so no.
Okay. In your statement, you have acknowledged that staff transmission was a large part of the extent and severity of the Newmarch outbreak. Right?
Yes.
That 34 Newmarch staff tested positive, which was a very high number. That's your evidence.
You want me to elaborate?
Well, just before I do, and you also said that in any further, this is one of your recommendations, in any further residential aged care facility outbreak, I would suggest universal testing of staff commence immediately upon the outbreak being identified and be continued. right? Now, clearly, staff are moving around the facility.
Yes.
Right, isn't it? Staff can be a vector for infection.
Without PPE, yes. With PPE, much less efficiently.
Right. That's assuming, of course, that PPE is being donned and doffed appropriately and used appropriately, right? There's an assumption there.
Yes, but what we now know is donning and doffing is not the essence of PPE. The essence of PPE is mucosal covering of mouth and mucosal membranes in the eyes and really good hand hygiene. In fact, in many of our COVID wards now, it's acceptable to not have a gown and gloves on, but to actually use eye protection, N95 and hand hygiene as a strategy. So, yes, that was the view at the time, but I think with what we now know, it's interesting to just make that point.
But when you say the view at the time, are you talking about the time of your statement?
No, at the time of Newmarch.
Because in the statement that you put on, which obviously was written after the events, your evidence, I read it to you, paragraph 227, staff-to-staff transmission was a large part of the extent and severity of the Newmarch outbreak.
Correct.
Are you walking back on that evidence?
Not in any way, and I'm happy to put some context around my thoughts on staff transmission if you felt that appropriate.
Well, yes.
I've thought a lot about Newmarch over the last 2.5 years, and I actually think we have two outbreaks going on, and I think the staff outbreak is actually the primary outbreak. And I say that for a couple of reasons. Firstly, I know the genomics of where this virus came from, and it was connected to an outbreak, and I don't know whether I should say the name of the other outbreak, Your Honour.
No, I don't think you should. And I'm going to just stop you now, Doctor, on this aspect of the evidence. That view has been noted, that you think the staff outbreak was the major part of the outbreak, and we may come to that later, but that's just moving into a different area, which is more in the field of epidemiology. At the moment, I just want to ask you about the facts of what happened. And what seems to be clear is that at the time, there wasn't a systematic approach to staff testing. That is when the outbreak commenced.
Correct. Opportunistic.
It was opportunistic. What was the average turnaround time in terms of performing a swab and getting a test back at this time during the outbreak?
At this time, the laboratory was under intense pressure.
Yep.
The workload had gone up by 500%. The technique we were using to cope with that workload was to pool specimens. Would you like me to explain?
No, I just want you to answer the question, what the average turnaround time was.
I don't know the average turnaround time at that time. I know the target turnaround time.
Target was?
Target was 24 hours.
All right, but you were on the ground, you're getting the results. You must have a sense of how quickly those results were coming through. Were you meeting that target generally, or were you usually waiting for a longer period of time to get those results?
My recollection is that there were delays on the weekends, that the turnaround time would blow out on the weekends.
Right.
We were also... So if I can just separate the timing a little bit and explain what the laboratory was doing, we were getting community swabs that were coming in. Everyone was worried that they may have COVID. The numbers were huge. We were also getting swabs from Newmarch. And we made the laboratory decision to prioritise Newmarch over the other work.
Go there on Monday.
And in fact, we moved the conventional work to a second laboratory, at, the veterinary laboratory at Elizabeth MacArthur. And that was done to try and drop the turnaround times on the Newmarch specimens, because I acknowledge that there was a period when the turnaround times were longer than we were aiming for.
So we've got a range of time that test results are coming back. Target 24 hours, not always meeting that target, sometimes greater delays. So we're talking sometimes days to get results back. Agree?
I think days would be unusual. I'd need to look at those specimens. 1.5, maybe 2 days at the outset.
Was there an issue in terms of staff testing that as staff started to be turned over at an increasing rate, that there were difficulties in being able to test those staff in a timely fashion, given the delays in getting the results back?
But at this stage, we're not doing systematic testing of the staff.
So what I'm getting at is, did that logistical problem factor into the decision not to conduct systematic testing of staff?
Oh, I see. No, I don't think so. I think the conventional wisdom had been only test staff that were symptomatic.
Right.
So to push forward and test all staff, particularly repeatedly, was controversial.
But if a systematic staff testing approach has been followed, then you would have had staff working at the facility while you're waiting for their results to come back. Is that the way it would have worked? And then, depending on how quickly those results came back, you would get confirmation that the staff was negative or positive.
Correct.
Do you recall having a conversation with Ms. Giles in the first week about infection prevention and control issues?
I don't. However, I heard Miss Giles' evidence.
Right. I mean, just to remind you, what she said in her statement, paragraph 33 of her statement, which is at volume 23, tab 5, is that she spoke with you and Robert Robinson, saying words to the effect, "I'm a little bit concerned about the fact that there doesn't seem to be any delineation going on here with COVID-19 positive residents and COVID-19 negative residents, and the staff are in corridors and offices with all the PPE on. Why are we doing this? It doesn't make sense to me." Do you remember a conversation to that effect?
I remember hearing it last week. However, I can remember the issues.
Right. What she then goes on to say is Dr. Brownlee and Mr. Robinson agreed that changes should be implemented, including that PPE, such as gowns and gloves, should not be worn in corridors or offices. I also discussed using different PPE for COVID-19 positive residents and those who were COVID-19 negative to ensure compliance with the CEC, the Clinical Excellence Guidelines. Again, do you recall a conversation along those lines occurring?
I don't have exactly the same memory as Christine, but I will accept her memory.
And were you aware of those matters that Ms. Giles brought to your attention before that conversation? Had you observed that yourself, being on the ground?
Yes.
Were any steps taken by you at an earlier point in time to address these matters?
I'm sure I would have done some things. I remember helping delineate issues when people brought issues, and one of the difficulties in infection control is that issues come to you which are what I would describe as technical breaches, and I think there is a difference between technical breaches and major breaches, and I think if you are using a cohort strategy in individual rooms, you going back to the red line idea, your red line is at the door of those individual rooms, and so where there's breaches at the door level, I think I would have been prioritising those over whether the trolleys look tidy in the corridor or not, if I can use that as a broad analogy.
But these matters that I've just put to you, as related by Christine Giles, they're not technical breaches, are they? Absence of delineation with COVID-19 positive residents and COVID-19 negative residents and the staff in the corridors and offices with all the PPE on.
So let's pull that apart, perhaps, because there's a lot there. So
doesn't seem to be any delineation going on.
The issue about the office, and I assume it's the control centre at the front, I do remember somebody made the decision to change what we were doing, and so the office at the front was not a PPE area, and I came in one day and somebody had changed that to putting PPE in there, which I didn't think was very sensible, and I would have agreed with Christine on that matter.
I mean, staff moving between areas with COVID positive and negative residents, that's not a trivial matter, is it?
It depends on what actually happened there, and you can have, and we did have, a positive patient in a room next to a negative patient, and you can nurse those two provided you know to change your gear between. If Christine's saying they were going with PPE from one to another, between positive and negative, then that's a major breach, yes.
Isn't that exactly what she was telling you? I also discussed using different PPE for COVID-19 positive residents and those who were COVID-19 negative. Isn't that exactly what you raised?
I will accept that that's what she said. I don't remember the conversation.
So again, I put it to you that the subject of that conversation, that doesn't relate to technical inconsequential breaches.
Part of it does. The office issue may not have been terribly worrying, but if what you described was occurring, then that is very worrying.
Did that conversation have any effect on you in terms of things that needed to be done at Newmarch House? Now, I appreciate that you're having difficulty remembering the precise conversation. What I'm asking you now is that after this exchange with Christine Giles, do you remember doing something, changing approach in any way?
Yes, and if Rob Robinson was there with me, we were doing a round and looking at those issues and implementing change.
I take it that in an early period of an outbreak, infection containment is important.
Yes.
It's a critical period, isn't it?
Yes.
In terms of containing spread.
Yes.
If there are breaches occurring of significance, that's a major problem, isn't it?
Yes.
I want to change tack now and move to meetings that occurred on the 16th of April. Now, did you meet with government officials on the morning of the 16th of April? Do you recall?
I don't recall, but please, I'm sure you'll tell me.
I suggest that you were present at a meeting that was conducted at 9:45 in the morning. So that is some hours before the big 12 noon meeting that occurred. Does that accord with your memory?
It doesn't, and my memory of meetings is completely blurred.
All right. Just to set the context, at 16 April, there were 20 cases amongst the residents of COVID. Accept that?
I'm sure what you're saying is correct.
And 10 staff members. So at that stage, things were progressing.
Yes.
I remember seeing a piece of evidence along the lines that you conveyed to certain people around this time, hot off the press as it were, that there were 20 results, 20 positive results. Do you recall something like that happening?
I don't.
Right. Can I suggest that as at 16 April, you knew that positive cases were spread across the three wings?
I'll accept that.
Just try and put the best you can, put yourself back into your shoes. 16 April, you know that there's a big meeting that occurs on that day, right? What was your belief as to the extent of the spread of the contagion through the home at this stage?
I would have thought that this is a really grave and difficult situation.
Major outbreak?
A major outbreak, yeah.
Did you expect at this time that case numbers would climb?
It's almost inevitable that what you discover initially is a fraction of the problem.
Given that you were there on the ground, you must have also appreciated that the staff shortage problem was already rearing its head at Newmarch by the 16th of April.
I can't... I have so many images of Newmarch in my head that I don't have an image of what that issue was up to.
All right. Well, I don't know if this will assist you, because you can only remember what you can remember, Doctor, but there's evidence in this inquest that as at the 14th of April, 40 staff, or about a third of the workforce, a little more than a third of the workforce, had been furloughed. And that Mabel agency staff, so agency staff brought on through the Mabel program, had commenced working by the 16th of April. Right? Does that accord with your blurred memory? I think
I'll accept it.
You'll accept it as a fact. I mean, what I'm working towards is this question. Were you aware, as at 16 April, that the system was already under strain?
Yes.
Now, you don't have a recollection of attending a meeting in the morning. What I'm going to do is put up a note of a meeting. It's volume 20, tab 124. And it's not your note, I should say, out of fairness. So this is a note taken by Ms. Stephanie Williams from the Department of Health. You know Stephanie Williams?
Yes.
You were talking to her throughout this time as a Department of Health official?
Yes.
Okay, so this is her note of a meeting with Commonwealth Department of Health, 16 April 2020 at 9:45 in the morning. And if we can just go down about 8 or so dot points, just above that list of indented dot points, do you see it says there, James Branley provided overview of current situation and what support the Nepean Blue Mountains Local Health District had put in place. You see that there? And there's some specific information that's provided under those points.
Yes.
That's the basis upon which I put to you that it's likely that you're present at the meeting at 9:45.
Yes.
Just going back up to the top of that note, Commonwealth advised purpose of meeting was to discuss Newmarch and the way forward, including consideration of the need to move residents out of the facility. Do you see that?
Yes.
Noted 9 infected residents so far, and likely more will be identified positive with further results due today. See that there?
Yes.
Now, I put to you earlier that by 16 April, there were 20 positive cases. It may be that as at the time of this meeting, some test results hadn't been assimilated yet. But at least at that point, there must have been some information going around that there were 9 infected patients.
I'll accept whatever you tell me.
The Commonwealth noted the facility currently quite full and that may be difficult to cohort. Commonwealth keen to look at moving out COVID-19 positive residents, potentially relocated as a group. Do you have a recollection of Commonwealth representatives right from the beginning of discussions about the outbreak raising the possibility of COVID-19 positive residents being moved out of the facility?
Yes, I think it was stronger than raising the possibility.
I didn't want to colour it too much, but I
think
you're right about that.
They wanted a mass evacuation of 97 patients.
They were pushing stridently for that outcome. Is that right?
They seem to only have that as the only option.
Well,
and I oppose that option.
Can I suggest that part of your answer is not quite right? That we've seen notes of other matters that were raised in meetings, for example, about moving out COVID negative patients. That's another approach they spoke about, right?
Yes.
And there were discussions, many discussions about, from their perspective, accelerating the cohorting process. You recall that?
I object to this, and this will need to be done in the absence of the witness.
All right. Dr. Branley, would you mind just waiting outside the courtroom for a short moment? Thank you.
Now, there's 2 issues. The first is that the witness was specifically requested not to look at any document that he didn't author himself, and he's now being confronted with them in the witness box. The second is that this is dealt with in his statement and he's not being taken to it.
Well, I hear those objections. In my respectful submission, that is not a basis, neither is a basis for me to curtail my examination and not be able to ask the doctor about his memory of what was happening. And in terms of taking the doctor to notes, I made it clear to him that it's not his note of the meeting. Certainly out of fairness, he should be given the opportunity to read the notes if he's not familiar with them, so that he has opportunity to respond. But again, in the context of an inquest, where there are notes taken by various participants, sometimes we don't know who the note taker was, of meetings, importantly, at which Dr. Branley was a participant, I should be permitted to put to him notes taken by others and to ask him whether that is an accurate record of what occurred. Now, if the objection is that I didn't do that at intermediate step because I didn't sense any resistance from the witness about it, then I'm content to ask that intermediate question, whether that accords with his memory, whether there's anything there that he'd wish to dispute. but I should be allowed to ask him about meetings where he participated, where we have a contemporaneous note taken of the meeting.
But my friend also has access to a statement from July of the same year that deals with these issues in circumstances where 2.5 years after the event, the witness says, I don't remember. Perfectly sensible. Directed not to look at the documents he's now being cross-examined on. In my respectful submission, this should not be permitted.
Well, I don't know that that Dr. Branley's been asked specific questions about the content of a note that he did not author, but where the note speaks about a meeting that he was present at. Right now, I think Senior Counsel Sting is only using the record of the note and notes about certain issues to ask Dr. Branley about his understanding of them.
Yep, sorry, and I shouldn't raise my finger.
No, not at all.
He's just been challenged on the accuracy of a recollection based on, I suspect, another note or part of a note that he didn't author and that he was directed not to look at before he came to give evidence in circumstances where his statement deals with this issue.
Well, I think, my note is that Senior Counsel Sting asked a question about whether the Commonwealth had begun to raise the possibility of moving residents out of Newmarch House, and it was Dr. Branley who indicated that his impression was that it was more than a possibility and put in stronger terms. And then Senior Counsel Sting sought to, and then Dr. Branley gave a further answer which indicated that, in his view, that was the only option put forward by the Commonwealth, and Senior Counsel Sting sought to explore whether or not that was the case based upon other evidence available. I think that's where we are, where we're at with the question, or with this topic.
He is being challenged on his credibility in circumstances where my friend has access to a statement from July of that year dealing with these issues, where he's been directed not to look at the documents that he's now being cross-examined. And I don't use this word very often when I take objections. It is not fair.
I should respond, Your Honour. First of all, I don't understand that I did challenge Dr. Brantley's credibility in respect to this note. I'm just asking him about whether he was present at a meeting. He's told us he doesn't remember. I've taken him to a note to see if it assists in his memory. That's the first thing. Second of all, in respect to the statement, that statement, first of all, is in evidence in this inquest. So Your Honour will have obviously regard to it. The witness is aware that the statement is in evidence. Second of all, the witnesses, I presume, had access to his statements. He's aware of what's in his statement. If he wants to raise a matter therein in response to these questions, he's perfectly entitled to do so. But the idea that I'm somehow obliged to take him through what is a very carefully prepared statement at each and every point to, in effect, filter his evidence through the way it's been set out in that statement would be an unreasonable constraint to place on examining counsel in this context. There is no unfairness. The statement is in evidence. The witness has had access to his statement. He is free to go to any part of it as may be, but I'm not intending every time a relevant matter is discussed in the statement to take him to the statement first and elicit from him what he said in his statement. That's not going to assist, Your Honour. You have that version of events, and Your Honour will take that into account and give it the weight it is due in light of the oral evidence that the witness gives.
Yes, Mr. Forden.
He says he doesn't remember. He's not given the opportunity to refresh his memory from a document that's more contemporaneous and then being taken to a series of documents he was directed not to look at. I would like a ruling on this.
Well, I propose to allow the question. I agree with what Senior Counsel Sting has outlined regarding the approach taken in relation to not only the evidence of Dr. Branley, but the approach taken to evidence generally to be adduced from a witness. As I said, we're now looking at the specific question that Dr. Branley was asked and that was being objected to. He's being asked to, in effect, other aspects of evidence are being posed to him in the context of an answer that he gave, which was, in one sense, not entirely responsive to the question asked by senior counsel assisting because it went further than what the question was actually asking. So I propose to allow the question.
Please.
Could I just raise a separate matter just while
Certainly.
the witness is out of the room? And it relates to an earlier topic. It just took us a while to turn up our note of the evidence given by Christine Giles in the inquest. My learned friend, senior counsel assisting, suggested to Dr. Branley that the effect of Ms. Giles's evidence was, in effect, that serious PPE breaches in the sense of people not changing PPE when they moved or between nursing COVID and negative residents. That was not the effect of her evidence. Our note of her evidence is that the concern she raised with Dr. Branley in the presence of Robert Robertson on the 17th was about PPE overuse, and that the issue was whether or not there could be a difference in the level of PPE as between COVID and negative, and not that they were in effect going from nursing a positive person to a negative person. So in my submission, it is a factual assumption put on the basis of Christine Giles' evidence that was put to Mr. Branley. So if it's not correct, his evidence falls away. But if that issue is to be revisited in my submission, in fairness, what we say is the truer effect of her evidence will be put to Dr. Branley.
All right, thank you.
Please, the court.
Well, and I put questions to Dr. Branley based directly on what Nurse Giles, Christine Giles, had said in her statement, directly from the terms of that statement. I've read the relevant parts that provided the foundation.
Yes. Look, I think that you referred to paragraph 33 of Ms. Giles' statement. That's my note of it. I don't know that in the context of those series of questions you were taking Dr. Branley to aspects of Ms. Giles' oral evidence.
No, it was based on what she put in her statement.
Yes, all right, very well. Ms. Richardson?
Well, the witness statement at 13 is, there doesn't seem to be any delineation. In my submission, my learned friend went further, and the suggestion was put to Dr. Branley that people were going from nursing a positive patient to a negative patient with breaches of PPE in that process, which is not the effect of her evidence.
Yeah.
My note is that after the reference to paragraph 33 of Ms. Giles' statement, senior counsel assisting then went on to ask some questions about staff, effectively staff movement amongst common areas, and then different PPE being used for both positive and negative residents. I don't have a note of whether the evidence went further than that.
I went from 33 to paragraph 34.
I see. All right.
And I can put up those paragraphs on the screen if Your Honour wants to see them now, to see what's contained therein. The relevant reference is volume 23, tab 5. Paragraphs 33 through to 35. Yeah, no.
Well, the transcript, when it arrives, will reveal what Ms. Giles' evidence was and whether what my learned friend put, and the evidence Dr. Brownlee gives will only have force if it matches up to underlying evidence.
Yes. All right, very well. Thank you. We can have Dr. Brownlee back, please.
It's 11:27. Does Your Honour wish to continue at this point or take the momentary break?
Look, I think we'll continue for 5 minutes or so more.
Thank you.
Thank you, Dr. Branley. Apologies for that delay.
Thanks, Your Honour.
Dr. Branley, I was asking you about a file note of a conversation, and I'll ask that it be put up again, volume 20, tab 124. Now, as I indicated to you before, this is not your file note. This is the file note created by Ms. Stephanie Williams from the Department of Health. What I'd like you to do is to just cast your eyes over that page.
Yep.
Now, first of all, does that jog your memory about whether you were present at a meeting at 9:45 in the morning?
I'll accept that I was there.
Do you accept that this is a contemporaneous file note of the meeting that occurred?
I'll accept that, but I won't sort of vouch for the contents. It's not my note.
Understandable. I'm going to ask you about some aspects of this note. If you recall things differently, then say so. But so far, I've asked you about those first 5 dot points or 4 dot points that concern a position taken by the Commonwealth, and you have indicated your recollection of the position the Commonwealth was taking, which was to pursue these options. Now, you remember evidence was given about the Commonwealth, you said it was stronger than raising a consideration in relation to moving COVID positive patients out, right?
No, my recollection is they wanted the whole facility decanted.
The whole facility evacuated.
Whole facility evacuated.
Right. Do you recall, though, at various points in time in this early phase, that representatives of the Commonwealth agencies were proposing that the COVID positive patients be moved out of Newmarch House? Do you remember that proposal being made?
No. I remember them non-specifically putting proposal to move the patients out, and it was unclear whether it was positives, negatives, both, and it was unclear what the plan was. That's my recollection.
That's your recollection?
Yes.
And are you giving evidence that that was your understanding at this point in time, 16 April?
Yes.
That a proposal had been made to evacuate the entire facility, and there'd been no further nuance to that position put by Commonwealth agencies. Is that your evidence?
The other thing I remember is just repeated telling us to cohort, as if that was a magic statement.
You're coming back now to the question that drew the objection. I was asking you just before your evidence broke off whether you recall that at some point in time Commonwealth representatives were inquiring about the possibility of decanting COVID negative patients out of the facility. Do you recall that happening?
I recall them arguing that we should move all the patients out of the facility and we should cohort. So despite repeatedly asking for an explanation as to what they meant, that was what they kept saying.
So is it your evidence that at this time you did not understand that the Commonwealth was raising for consideration moving COVID positive patients out of Newmarch House?
I did not understand what they were suggesting, because it was unclear to me except that they wanted to move patients.
Wasn't what was happening here Precisely that. COVID positive patients being moved out of the facility. That's what the Commonwealth agencies were recommending.
That's not my recollection.
And you were pushing back against that idea.
That's not my recollection. My recollection is they wanted the patients moved, all of the patients.
You, can I suggest, took an early position. That early position was, in the interests of infection control, the Newmarch residents should stay in place at the home.
Yes.
No question about that, is there? That's the position you took right from the outset.
That was my position at that meeting, correct.
And that position emerged, can I suggest, and hardened in the course of a debate that was going on.
Yes.
And that debate was largely between representatives of the Commonwealth Department of Health and the Aged Care Quality and Safety Commission on the one hand, and those representing New South Wales Health on the other.
I don't remember it that way. I remember that that there was one person throwing around words like decant and cohort, and despite numerous attempts to get further information as to what the plan actually was, I was unable to.
Do you say that you were asking for details?
Yes.
During these early meetings for what these plans would involve?
Yes.
And you say, do you, that no details were provided?
No details were provided. It was just cohort and move.
Let's just go back a step. Did it ever come up for consideration? And at the moment we're looking at 16 April because some important meetings were held on that day. Did it ever come up for consideration that COVID positive patients should be moved out of Newmarch House?
I remember that there was a discussion, well, not a discussion. I remember that meeting was very difficult because there wasn't any detail as to what was being suggested. In fact, I felt that I needed to get out of the way because that situation wasn't going anywhere.
Can I suggest to you that at this time, I'm talking about by no later than after this 9:45 meeting, on the morning of the 16th, you well understood that the Commonwealth agencies were pushing for the removal of the positive COVID cases from Newmarch House, that you well understood that.
I don't remember it that way.
Can I suggest to you that you, after the meeting, went and had a conversation with your superior, Ms. Hyman, where you discussed that very position that the Commonwealth was taking?
I remember a conversation with Kay where I was saying, they just kept saying cohort and cohort.
Right, not removal of positive cases.
Well, I don't remember clearly, but that's my recollection.
Do you recall, and if you don't say so, do you recall at that 9:45 meeting discussing Dorothy Henderson Lodge?
I don't.
Do you recall saying something to this effect? You need to understand what is in place prior to making decisions to move residents.
I don't remember those words, but...
Is that the sort of advice you would give in the context?
Could you just repeat it again?
Object.
Please finish the answer. I didn't mean to cut you off, Doctor.
Could you just repeat what the quote was?
The quote was, need to understand what is in place prior to making decision to move residents.
I think I would say my view at that stage was I needed more information before making a decision.
In the part of the note that refers to an overview provided by you during the meeting, you can see that, those dot points in front of you? It's not up on the screen anymore. Could that come up, please, again? Sorry, Doctor. Paragraph, tab 124. So do you see there the dot points under the heading James Branley provided overview of current situation?
Yes.
Doesn't that accurately reflect your thinking at the time?
All of the dot points. This is reading down.
Yes, just those indented dot points under the dot point that has the heading James Branley provided overview of current situation, colon.
Patients are in individual rooms and effectively co-ordered, yes.
That was your view at the time, wasn't it?
Yeah, yeah. I don't know that facility's been locked down since Easter. It was actually locked down before that, but anyway. The screen Tuesday, expecting the number of COVID-19 to rise today if results. Yes.
Does that reflect the views that you had at the time?
Yes.
That summary. Do you think it's possible that you did say those things during the meeting?
It is possible.
Do you think it's likely you said those things?
I think my views were that I thought what the Commonwealth was proposing was dangerous.
Well, what did you think they were proposing?
I think they were proposing an evacuation of the facility.
A mass evacuation of the entire facility?
Yes.
Not moving out the COVID cases, moving everyone out?
Well, it wasn't clear to me. It wasn't clear to me what they were proposing, but I was concerned that there did not seem to be a coherent plan.
Right. It's important to distinguish between your thinking about this now and what you're thinking about at the time. And the evidence I understand that you're giving is that at the time you didn't think they had presented with a coherent plan. That's the first part of your evidence? Or a plan with sufficient detail?
So I'd go back to saying I can remember more about the emotion of this meeting than about the substance. But my thinking on that meeting afterwards and now is that what they were suggesting was dangerous.
When you say you remember the emotion of the meeting, what do you remember about the emotion of the meeting?
I remember that it was an antagonistic meeting. And I think when you're managing a difficult situation, people coming from outside with antagonistic sort of approach, it doesn't fill you with confidence that they have a well thought out plan that can be executed. I guess I was operationally dealing with a problem and I was looking for help, and what I was getting was not a coherent plan.
Yeah. Your Honour, is that a convenient time?
Yes, it is.
Thank you.
Dr. Branley, we're going to take a break for morning tea now. We'll continue after that. We'll come back at 12:10.
Coroners Court
Oh, no way.
Thank you, Anna. Dr. Brownlee, I was asking you about that meeting at 9:45 in the morning. Now, after that meeting, did you speak with Kay Hyman?
Yes.
Who is Kay Hyman? What was her position?
Kay is the Chief Executive of Nepean Blue Mountains LHD.
Does that mean you reported to her?
I reported to her.
Was she higher up in the hierarchy at the hospital?
Yes, although it's a little...
More nuanced than that?
It's nuanced, yeah. I actually work for New South Wales Health Pathology, so I've known Kay for a long while, and I work in the hospital as an infectious diseases physician, but my primary job is within pathology, and as such, it's not a direct reporting line, but she is a chief executive of the LHD where I work, so yes, she's my superior.
Right. What would be the purpose of speaking with her at this particular point in time? And just to give you the references, 9:45 there appears to have been a conversation or teleconference of the kind
Yep.
related to the notes I just showed you. You know that at 12 o'clock there's another
Is there?
meeting.
Know that,
But I'm going to come to that in a moment. There is definitely a meeting that occurred at 12 o'clock between a number of senior people, and I'll be suggesting to you that you were present at that meeting.
well, look, I can't remember, but what would be the point of talking to Kay? I think it was essential that Kay be in every loop, and my recollection is there were meetings happening all over the place, and to be honest, I'm not sure I knew who was who in the zoo, and Kay was a reference point, really.
Do you have any recollection of the conversation that you had with Kay
I can only
Hyman?
one line of the conversation I had with Kay, I think, which is that the Commonwealth want us to cohort. And I found that suggestion to be so obvious that that I found it extraordinary that we have to have a meeting to discuss cohorting. What I really needed for cohorting was people on the ground to help. Sorry, your question.
No, I was just asking you about your recollection. So just to summarise, you do or don't recollect having a conversation with Kay Hyman
I recollect having...
after 9:45?
I can't say that it's that day, but I'm pretty sure it's the meeting you're talking about. I recollect having a meeting, or a conversation with Kay rather than a meeting. And I found it incredible that the level of discussion we were at was around cohorting, because we'd been attempting to cohort for some time.
And just tell us your best memory of when you would have had this conversation with Kay. I've told you to use as markers 9:45. There appears to have been a conversation with Commonwealth agencies.
I've got no idea.
At 12 o'clock, another meeting.
My recollection is probably that I would have said the meeting was, that we only had one meeting and it was 12 o'clock. So my recollection is obviously not right.
I'm going to ask now that this file note be put up. It's tab 123 of volume 20. And we understand this is a file note that was prepared by Ms. Hyman. And I want you to just look at the top section. You can see the date 16 April. And there are the initials JB. I'll just read it. Concern Ray facility desire to transfer not understanding IC principles, which may well be an acronym for infection control, 1.5 hour teleconference, 0 agreements, want to relocate demented wanderers, don't want help, not listening. Anne and Lisa, Commonwealth, pushing for removal of cases. And I just want to give you some further context. Anne is probably Anne Wunsch, who was an officer with the regulator, the Commission, and Lisa is probably a reference to Lisa Peterson, who was representing the Commonwealth Department of Health in meetings. Now, just looking at that note, does that jog your memory in terms of a conversation that you may have had with Ms. Hyman?
No, it doesn't. What it does jog my memory for is the confusion. And even when I read this note now, there seems to be lots of different pushing and pulling in different directions. I'm not quite sure I've read that note correctly, but I think it was confusing.
Confusing in the sense of the different options that were on the table?
The different players who were suggesting ways that they would do it without actually being involved at the facility. And I mean, I think what we needed was a small group of decision makers who were actually across what was happening at the facility, who were actually prepared to come down to the facility and help. But people on the phone making all sorts of suggestions, I found it confusing.
Is the effect of that evidence that it would have been your preference at the time for others, including the Commonwealth agencies, to be out of the picture?
No, I think they should have come down to the facility, and we should have actually had a small group of high-level operators work out how to do this.
Right. And in the absence of that occurring, is it your view that their contribution in these meetings was counterproductive? Is that what you're saying?
Yes. I think they were stating the obvious and vehemently stating the obvious, to a person who, essentially knew the basics.
Who's that, you?
Well, I knew the basics.
In the sense that you'd been there on the ground?
I'd been there on the ground.
Is that what you mean by knew the basics?
Yeah, that's right. And to have lots of people on teleconference, and this was consuming large amounts of time.
Is this a view you had in real time, 16 April?
Absolutely. I had work to do, and people were wanting to sit around having 2-hour meetings to tell me to cohort the patients. And, that is the bleeding obvious. And we were cohorting the patients. We had them all in single rooms. We had them locked down, and that is a form of cohorting.
When you say you knew the basics, what were the basics that you knew that gave you this advantage?
Sorry?
I've just picked up on an aspect of your evidence. You said, I was the one who knew the basics.
No,
I just want to understand what you mean when you say I knew the basics. What is that information?
Well, I wasn't the only one who knew the basics. Christine Giles knows the basics. Kathy Dempsey knows the basics. Lots of people, Rob Robinson knows the basics. There were people on the ground in the facility who knew the basics.
But what are the basics? That's what I'm asking.
Well, the basics are when you have an infection, when you have a very contaminated, if that's the word to use, I suppose, site, you don't move things around.
I see. The basics, when you say I knew the basics, you're not referring to facts on the ground. You're referring to the basics of infection control.
Correct.
The principle. That's what you're referring to.
Yes. And to have those reiterated by people who are not there, and to take up an hour and a half just saying over and over again, cohort, 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 is not a productive use of time.
Just look at the last part of that note, if it could be brought up again, please. and Lisa, and I'll just ask you to accept, that's Anne Wunsch and Lisa Peterson that's being referred to there, Commonwealth, pushing for removal of cases. Does that remind you of a particular conversation on this topic?
No, it reminds me that there was discussion about moving negatives, moving positives, moving the whole facility, and I don't think there was a clear plan.
Right, but there was a discussion about those things.
There was a discussion about evacuating different groups.
No, that's... Okay, you've just added the words now, different groups, and I just want to ask you this to be clear. So there was a discussion about moving positives?
I don't remember, but I would assume so.
A discussion about moving negatives?
I definitely remember the discussion about moving negatives because
Right.
there was talk of moving them to other nursing homes.
And there was a discussion about cohorting that was going on.
And there was a discussion, there was multiple repeating of the word cohorting.
And your view was that these other options weren't expressed with sufficient clarity that they were worthy of consideration? Is that a fair way to put it?
That's the first part of it. The second part is I don't think that was my decision.
But just picking up on an aspect of the answer that you gave before, which is they didn't understand the basics, and the basics are if you've got infected people, you don't move them around.
I didn't say they didn't understand the basics. I said there were people on the ground who did understand the basics.
Right.
And they kept telling us a magic word cohort as if you say it 5 times, it'll make a difference.
Had your views hardened early on, and I'm talking about 16 April, that the correct approach was to keep the residents at Newmarch House?
I thought that was the correct approach, yes.
And the question is, had your views hardened by this stage, 16 April?
You can probably tell even now I'm a little irritated by remembering that because I felt it was wasted time and we really needed help. And
Right.
I didn't think this was productive use of time.
Right, so doesn't that mean, putting all of that evidence together, you've taken this view, this is the way that we should be moving forward, and now provide us with some practical assistance in managing this situation?
Correct.
Is that a fair summary of where you were at this stage, 16 April?
I think that's a fair summary.
Now, you've indicated that you're having difficulty separating out the two, the 9:45 and the 12 o'clock meeting on that day.
I have no recollection of there being 2, but anyway.
Yeah. Will you accept from me that there was a meeting at the 16th, on the 16th of April, and there are notes in the brief of evidence from various persons who were participants in that meeting. So we've got more than one set of notes about that meeting. Can you just accept that from me? Do you recall on the 16th of April, I'm not going to now direct you to a particular meeting because of the state of your memory about when things occurred, but do you remember that there was a meeting with a number of officials where you provided an overview of the hospital in the home model?
I will accept that there was.
Can I ask that volume 20, tab 124 be brought up on the screen, please? This is a continuation of that file note created by Stephanie Williams that I showed you beforehand. Now there's part that deals with 12 noon. If you just look at the list of attendees that are recorded there, you can see your name third in the list.
Yes.
You can see, just cast your eyes over the other participants. Can I ask you then, when you've done that, to move down to the second half of the page, which starts with the words, James provided overview of HITH model.
Yep.
I had a chance to read that, Doctor. Do you agree that having a look at the list of the attendees,
Can we go back up to that?
yeah, which is at the top of the document, that if someone was in that group was going to be likely to outline the overview of the HITH model, that would be you in the meeting. Would have fallen to you to do that.
Yes.
Having a look at that list of dot points under James provided overview of HITH model, does that jog your memory about the content of this meeting?
Yeah, it doesn't. I don't have a memory of this meeting, but I'll accept that somebody's taken, well, Stephanie's taken these minutes, so.
The next question, noting that you don't have a memory of it, is to ask you this. Do you think that those are things that you would have said during the meeting?
I think it's quite likely.
Right. And I suppose the point is this. Does that description that's given there convey what your expectations were, as at 16 April, about what level of service delivery HITH could offer?
Yes.
And that included that there would be VAC's involvement, including the involvement of a VMO, which stands for
Visiting Medical Officer.
And an NP, nurse practitioner, that HITH would ring each day for the observations and plot the course for each of the patients.
Yes.
That would occur sometimes 2 to 3 times a day.
Yes.
It says make decisions about oxygen.
Yes.
Indicating from the context of the note that it's HITH that would be making decisions about oxygen. Is
Well,
that how you read that?
No, the way I read this is not a standard HITH model. This is an augmented HITH model.
Involving the VACs as well.
VACs and intensive care, respiratory. This is an insertion team, really.
Right. So then you go on to talk about palliative care clinicians being involved, and if the need for ventilation arose, an ICU specialist would be involved.
Yes, that's right.
Now, do you see over the page, there is a section, a note that starts near the top, discussion on decanting.
Yes.
And then there are views that are attributed to you.
Yes.
That providing care in situ will reduce the spread, the advantageous geography of the facility, effectively.
Yes, I'd accept all of that.
You've accepted all of that. And then there's a part that's attributed to Melanie Roth, who you understood was the Chief Clinical Advisor to the Commission.
Yeah.
And Anne, her name's misspelt there. about advocating the need for decanting?
Yes.
And I think we've got to the point where you've accepted there was a discussion about these issues, right?
Yes, and if we go down to move residents to Rooty Hill, I certainly remember that.
Right. That was one of the matters that arose for discussion, perhaps moving residents out to another facility at Rooty Hill.
Yes, and can I note my concern with that idea?
Yes, you can. I mean, I think it's clear from the note you were concerned about who the true negatives were at this stage.
I don't think there were negatives. That is my point.
Are you saying by that your assumption at this time was that people who were testing negative were likely to be positive?
Correct.
So your assumption at this time was that the spread was far more widespread than the number of cases that had tested positive.
We already had evidence. This was throughout the facility. It was in every single bit of the facility.
But what was your concern at this stage? Were you aware that there were 97 residents at Newmarch House at this time?
Yeah.
You would have known that basic
Yes.
number. What was your concern at this stage about the number of positive cases amongst the 97?
The cat was out of the bag.
Right through the facility.
Absolutely.
So is what was being proposed at this stage that there be this hybrid model, hospital in the home and vax, to care for up to 97 COVID positive patients in a facility, in an aged care facility? Is that what therefore was being proposed?
Well, you need to understand my concept of my belief about HIF, because it's not the way this Coroners Court has necessarily regarded HIF. And that is that HIF has always been a shared care model with general practitioners.
So just explain what we want to understand, what it is that you understood was the model that was going to be, I'll withdraw that. What was the model that you were proposing as at 16 April? Because clearly you're proposing a model, aren't you?
I'm proposing an insertion team to assist with the care of the positive residents in the facility.
And I really want you to be careful about just not trying to colour your evidence with what you know now.
Yes.
As at 16 April, what did you understand, was the nature of that intervention?
To assist in the care of COVID positive patients.
What was the composition of the team? You say it's not a hospital in the home team as is commonly understood. What was being proposed here, Doctor?
So what was being proposed, that we smashed together services who had all done some preliminary planning about COVID, and we have a cooperative insertion model to look after the COVID positive patients in the facility.
What does smash together mean?
Well, hospitals are somewhat siloed, and people do their own planning. People were doing their own planning in different departments for this facility, and I think this court's heard about the step-up plan. I think was Anita's plan, and we had a HIF COVID plan, and bringing elements that were familiar with the disease and familiar with elderly residents and familiar with the possible complications seemed to make sense to me.
In your earlier evidence, you referred to the objective being a spectacular failure. Now, specifically in the context of smashing together the different contributors to this overarching approach, is it your evidence that the approach that was implemented didn't correspond to what you thought was going to be implemented, the plan?
Yes, clearly, what I thought on that day had to be modified and modified and modified. The best plans often, when tested, need to be adapted and need to be changed. And at this stage, I was still thinking that HITH would have the ability to monitor the patients, which didn't turn out to be the way we thought it would. HITH then had to adapt and use VAX as its primary mechanism, if you like. And so things didn't go to plan.
Had you ever overseen an approach like this before?
Yes, but not
where and when?
Not on this scale.
Not on this scale. Where and when?
We had an outbreak of influenza in a nursing home in Cambridge Gardens or somewhere there, probably about 3 or 4 years before this. And Anita had rung me and said, we need HITH's assistance. And we smashed together our services and dealt with that influenza outbreak and kept the residents in the home. There had been 8 or 9 or 10 ambulances booked to take patients with influenza into hospital. And we managed to successfully do that, and it worked very well.
This was COVID, not influenza.
True.
You've just given evidence about your concerns about the extent of the spread, right? So you well understood this was going to be a major outbreak.
I didn't think there was a good outcome here.
Right.
I thought we were picking the worst of several, bad possibilities, and I thought this was the best possibility.
And that involved trialling an approach that hadn't been used on this scale before.
For good reasons, in a pandemic, with a highly contaminated site and a fear of dissemination.
We'll come to the reasons. That's an important part of your evidence. You mentioned before that HITH effectively didn't come up to scratch in terms of what you're thinking of at the time. I just want to drill down on what it was that you had in mind.
And my comment about spectacular failure was about the communication difficulties with HITH into the facility. That didn't work.
Right. But this part of the proposal, that is that HITH would ring each day for observations and plot the course of patients, sometimes ringing 2 to 3 times per day, if that was what was said, that's an aspect of the HITH, or an aspect of the model that didn't come to fruition. Is that right?
Yes, correct. If I could elaborate there, and it gets back to that idea that we would have a control centre to actually monitor the patients. And that's the way HITH works in the community as well.
Was that control centre ever established?
It was reliant on information. The control centre is in HITH in the hospital.
The control centre is Registrar El Jamali receiving information with his team, is that right?
With a team of residents.
Including Nurse Carpin?
And nurses. No, not Hayley. Hayley's in VAX.
She's VAX, I'm sorry about that.
That's okay. No, Gillian Hennessy.
Hennessy, that was the name, yep.
Yeah, exactly.
That was what you had in mind.
And, you know, the whole team back at Nepean. And what was a spectacular failure is the communication between that and the facility failed.
Right. What about the communication between HIV and VAX?
That wasn't too bad. It wasn't as good as I would have liked it to be.
What about the communication between VAX and the facility and their level of intervention of the facility?
That seemed to be pretty good from what I was seeing.
What were you seeing that gave you that impression?
Well, I was seeing Hayley and Kakat able to write in the notes, able to do rounds. I was seeing Anita able to video conference with patients. I was seeing...
When did you start seeing that?
I saw Hayley and Kakat, I think, on the, that first week at some stage.
I've told you what the dates were that are recorded in the notes about those people having direct consultations with patients, those 3 dates. And can I also suggest to you that Dr. Sharma didn't start having teleconferences until the 24th of April. It's 2 weeks or so after the outbreak commenced.
Right, well, I must have the time.
My friend put 3 dates. According to the brief, there are in fact 1, 2, 3, 4, 5, 6 dates before the 24th with Dr. Kakat, including the 24th.
If I've misstated the evidence, then I'll speak to a learned friend over lunch and I'll correct that.
All right, very well.
Do you remember saying during the 16 April meeting that you wouldn't support moving positive patients, but negatives might be able to be moved, although the chance of them becoming positive is high over the course of the first week? Words to that effect.
I think I would have said it the other way around, but I don't remember those words.
Do you remember referring during the meeting to the risk of a Ruby Princess situation?
Yes.
And not wanting to disseminate patients who are likely to be positive?
Yes, particularly to other nursing homes.
Right. Do you remember a representative of Anglicare named Gavin Pretorius being present at a meeting at this time?
I don't.
All right. Do you have any recollection of an Anglicare representative raising at this meeting on the 16th that it would help with the families knowing that their loved one is in hospital, and that would also be an advantage to their level of care? Do you remember him raising something along those lines?
I don't remember that.
After the meeting, on the 16th of April, do you recall leaving the meeting in exasperation?
I do. I obviously recall that because it was an emotional event, and I don't. I effectively offered my resignation, and the point of that was not to obtain an outcome, but you've always got to consider whether you're part of the problem. And I started to think maybe I'm not seeing this the way I should be seeing it, and maybe if there is a plan that I'm not seeing here, maybe implementing that plan can be done by other people. But I wanted to divorce myself from an unclear plan.
You joined the meeting by way of a telephone link-up, is that right?
Yes, it was all by telephone.
Right. Did you hang up at the end of the meeting? Leave prematurely, in other words. That's what I'm putting to you.
Oh, I don't remember doing that, but I do remember being exasperated.
Right. And do you think it's possible you did hang up and leave prematurely?
I don't remember that.
Do you remember confiding to a senior person at Anglicare something after the meeting?
I don't have any recollection of
Right.
confiding something. Or
Right. Do you remember having a conversation with a senior person from Anglicare after the 16 April meeting?
Well, the only person from Anglicare I spoke to in the whole time that I can remember, I was certainly getting conversations with David Goodhue. So there may have been a conversation with David Goodhue, I'm not sure.
I think your recollection is correct there, Doctor. It is David Goodhue that I'm referring to. Do you remember having a conversation with David Goodhue after this meeting?
I do remember being in communication with David Goodhue.
Right. Can I suggest that you confided with him after the call and said to him words to the effect that you would not be able to continue if you were not able to act as you knew best?
I don't think that's what I would have said.
Because that has a different character to it than the scenario that you have described, which is sort of stepping back magnanimously in the event that others had better ideas.
Look, the other thing is, we're at the end of the first week here, and we were heading into a big problem and something needed to be done. And I had proposed something, and I'd got in a situation where the Commonwealth representative had a different view, and I felt that I couldn't continue. I don't know what I was supposed to do according to the Commonwealth.
Isn't this the true situation? You had proposed what you thought was the appropriate approach. There were other voices in the meeting suggesting other approaches. Accept that part?
Yes.
You thought that other contribution was counterproductive. That's right, isn't it?
I don't think it was advancing the discussion.
Yeah, it's counterproductive.
Yeah, okay.
And you effectively threatened to withdraw unless your approach prevailed.
I wanted to withdraw, to be honest.
Sorry, are you suggesting that you would have been happy to step back at this point, have nothing more to do with the outbreak?
I would have been, and I still wonder if that isn't the right way to have gone.
And why do you wonder whether that would have been the right way to go?
Maybe I was part of the problem.
I mean, the fact that you turned up in the way that you did on the 12th of April would suggest that you had a high degree of motivation in terms of being involved.
I don't question anyone's motivation in this. It's just a difference of opinion as to how to operationalise your ideas. And yes, I had my ideas and I wanted to operationalise them, and I thought we could do it. I didn't know we could do it, but maybe I was part of the problem.
Just on that point, it was obviously an important part of your thinking that there was a collaborative approach of some kind, right?
I think it was
given the magnitude of the problem.
I think it was essential, and that meeting was disappointing because there was an antagonistic flavour to the meeting of do what we say, and I didn't, that was hurtful and difficult.
I mean, do you accept that indicating an intention to withdraw at this early stage, really after ideas were being raised on the first opportunity, is not particularly consistent with a collaborative approach?
I object to this because what hasn't been put is exactly what it is Doctor has said to a person. And I'm looking at statements and things at the moment, looking for these words. So I think if that question is going to be put, it's going to have to be specifically put that the doctor said particular words to a particular person, and I'd like to know the reference where it's coming from.
All right. Mr. Buchan?
Excuse me for a moment. The reference in respect of what I put to Dr. Brandley was paragraph 128 of volume 20, tab 6.
Excuse me, just give me a moment.
And I'll just read it.
I'd like to read it, please. Is it volume 20?
Volume 20, tab 6, paragraph 128.
Well, that's Grant Millard's statement. It's not Mr. Goodhue's statement, who had suggested he had the conversation with.
I'm sorry, I haven't read the paragraph myself yet. Just give me one moment too, please.
Paragraph, is it?
Yes, I can.
No, there's a significant problem with this.
Yeah, it's not entirely confused.
All right. Sorry, yes, Mr. Fordham.
Well, the problem with this is this just has to be hearsay. This is Mr. Millard's version of something he was told by somebody where that somebody hasn't come along to give evidence, and there is a statement on from that somebody, I think it's Mr. Goodhue, that doesn't mention it.
All right. Mr. Buchan?
Well, Mr. Millard has given evidence in written form about a conversation that he had with Mr. Goodhue following a conversation with Dr. Brandley. Is it being suggested that the hearsay rule prevents me from putting this to him as something that may have occurred?
Yes, it is.
We may seek to make submissions about this piece of evidence. The dictates of fairness require that I put this to Dr. Brandley and we get his response. He can disagree with it and say it never happened, and then Your Honour will be in a position to determine what weight to give this evidence. It may be that you won't make a finding after hearing Dr. Brandley's denial. But what's being put at the moment is the anterior proposition that I can't put the conversation to him at all because it's in a hearsay form,
Yes.
in a jurisdiction where the Evidence Act doesn't apply.
Yes, look, Mr. Fordham, my understanding of the evidence is that Senior Counsel Assisting has already put aspects of this paragraph more specifically to Dr. Brantley, and he's responded to them. But the current question that's being objected to is actually in broader terms, I suppose describe it in a summary form. That is that my note is that does Dr. Brantley accept that he indicated an intention to withdraw at an early stage in the course of the outbreak when certain ideas were being raised for the first time? I think that's the question that you're seeking to ask, Mr. Buchan.
That's correct.
So that's actually put in more general terms than the specifics of the earlier questions that arose presumably from this paragraph.
The problem I have, it's a summary version of a hearsay conversation where the person who's said to have received the conversation has a statement on that doesn't mention it.
Look, that's the case. I'm not in dispute, but if the objection is about the hearsay nature of what's contained in Mr. Millard's statement, those matters have already been put directly to Dr. Brantley. He's answered them without difficulty and without seeking to reject them. He's offered his explanation or version of them. I don't know that the current question is objectionable on that basis.
The problem becomes that a summary is being put where if it's going to be suggested that Dr. Brantley said something that was interpreted by somebody, it might be helpful to Your Honour if it was known what he said, alleged to have said.
Yes, I would agree with that, but I don't know that we're at that point or talking about that for the present moment. So look, I'll allow the question.
What I put to you is that at an early point, 16 April, after some other approaches had been raised, you already at that point were feeling exasperation and wanting to withdraw. Is that right?
Yes.
And isn't that inconsistent with a collaborative approach, which requires that you listen to other approaches and consider them on their merits?
I agree with you, and if I was not listening to other people at the time, I apologise. I was pretty tired and pretty stressed, and, you know, we were working in a fairly intense environment. Now, that doesn't excuse being short with people or not being overly collaborative, but I had enormous respect for the people on the ground that I was working with, and we were actively trying to come up with the right way of doing things. Now, in a difficult situation, being told very simple things simplistically over and over again in what I felt was an aggressive way might have made me, you know, a little irritated. Now, I don't know about comments to David Goodhue. I can't remember making any comments to him. But I would make a general comment that David struck me, and I never met him, but he struck me as an old-fashioned gentleman. And I doubt I would have used bad language or anything with David.
I don't think I've put to you that you used bad language or suggested anything of the kind.
I don't know what I'm being accused of here, but
The conversation that I put to you earlier was whether you said the following. That after you left the call on the 16th of April in exasperation, that you told Mr. Goodhue that you would not be able to continue if you were not able to act as you knew best.
This is what I'm objecting to, because this is a hearsay statement from Mr. Millard in circumstances where Mr. Goodhue, who has a statement on, could have been approached and wasn't, has not given evidence. And I'm just checking the Royal Commission transcript to see if Mr. Millard said exactly the same thing.
But this question's already been put to Dr. Brownlee today, as I know, and Dr. Brownlee's indicated that his evidence was he does not think that that's what he said, or what was said.
Well, then why is it being put again?
Well, that may be a different objection, but what I'm pointing out is that that question's already been asked and answered.
Well, then I'll adopt that, but
Very well.
It's being put again because the witness expressed uncertainty about what the conversation was that was put to him as a possibility and asked for his comment. So I'm giving him another opportunity to respond to that piece of evidence.
I do not remember that comment.
Thank you. It's 1 o'clock. Is that a convenient time?
Yes, it is. Dr. Brownlee, we're going to take a break for lunch. We'll continue, obviously, after that. We'll resume at 2 o'clock. I would note that I cannot sit past 4 o'clock this afternoon. I don't know how much left in the evidence, but that's not to put a constraint on any questions that Mr. Buchan or any other legal representative seeks to ask. Just pointing out that I cannot sit past 4 o'clock this afternoon.
Thank you. That's been noted, John.
Thank you. Thank you, I'll adjourn.
Thank you. Dr. Brownlee, if we can move past 16 April now. Is it the case that by the 17th of April, effectively, there was a consensus in place at that point in time that matters would move ahead with the model that you had proposed as the approach to be taken?
Yes.
Now, I just want to ask you some questions about the rationale, the reasons that you had for choosing and advocating for the particular model that was adopted. Okay, and I'm using the term "the model." Clearly, from your evidence, you're indicating that it's some type of hybrid model involving different elements, and we might come back to that in a moment. But I'll just call it the model. Okay. You've addressed the reasons for the position that you took, the rationale for the position you took, particularly from paragraph 120 of your statement. And I might use that as a basis to put certain things to you. The first imperative for you, can I suggest, was to avoid dissemination of the virus.
Equal first, yes.
I say first as in that's the first reason that you give in your statement in paragraph 120. But, excuse me?
Do you have a copy of your statement?
Do you have a copy of your statement with you?
No, I don't.
All right. That can be put up. Do you see there, paragraph 120? I advocated against this plan. The plan had a significant risk of disseminating the virus to other locations because the extent of the outbreak had not been defined, and residents that had tested negative to that time could still be incubating the virus. All right. So let's just break those things up. The first thing is the significant risk of disseminating the virus. That's the language that you use.
Yes.
Right. You've had the opportunity to hear other experts in this case address these aspects of the reasoning. And I'm going to put to you some of the matters that have arisen in their evidence and ask for your response effectively to them.
Yes.
First of all, do you accept that when it comes to avoiding the spread or dissemination of the virus, it's not just about containing the spread of the virus outside of the facility? Part of the thinking has to be about containing the spread of the virus within the facility.
Yes, obviously.
So one of the difficult tasks that had to be undertaken was to strike some sort of balance between managing spread of virus outside facility versus the spread of the virus inside the facility, right?
Yes, acknowledging that we were managing the spread of the virus inside the facility at our start, at that point.
Right. In terms of the issue of the virus spreading within the facility, was it relevant to take account of these matters, that you had a very vulnerable population within the facility?
Yes.
That particularly in the early stages of the outbreak, and by that I mean the first week, potentially up to the second week, there were severe staffing shortages at times.
Yes.
Notwithstanding the evidence that you just gave that we were doing things within the facility to address spread, that there were at least occasional lapses in infection control within the facility.
Very early, and obviously we'll get to the 20th, which I think was different.
That was a bad day.
Yes.
I haven't put it higher than that. There are occasional lapses in infection control within the facility, right?
Yes, whether they were important lapses or not, I think is uncertain in my mind, and I think some of the expert witness would attest to the fact that we actually cut spread despite what looked to be untidy infection control seemed to be highly effective.
Right. That's the opinion you've certainly put forward in your statement.
Yes.
That ultimately what happened was effective, even if it looked untidy at various points in time. Correct. You've drawn attention to the issue about whether every breach was a material breach, effectively.
With the exception of April the 20th.
Right.
And I would make that exception. My view is different on that day.
Right. Clearly, when there were times where there were significant staff shortages, there was the potential for a breakdown of proper procedures, right?
Highlighted on that day in particular.
Is it also relevant to consider that the home itself lacked certain advantages that a more controlled environment like a hospital has, in terms of, for example, having more consistent, skilled staff to hand? When I say more consistent, I mean more consistent numbers of staff present.
I think the...
Can I just finish the list? Entrenched infection prevention and control protocols that have been developed over time. Absence of soft furnishings, things of that nature.
I think the soft furnishings is a very, excuse the pun, but it's a soft one. The other two you mentioned, I think, on reflection, and I must highlight that wasn't my feeling at the time. My feeling at the time was, hey, this is pretty good from an infection control point of view. But listening to the expert witnesses, I think they did, and you know, my colleagues are very erudite in sort of expressing this, and I acknowledge that.
And then, of course, in the home, and you've referred to this specifically, there was the problem of wandering patients as well.
Yes.
That might be able to be better controlled in a hospital environment.
I would question that. I have seen a lot of wandering demented COVID patients in hospitals that really escalate in terms of their behavioural changes. And I've seen that cause infection in staff.
One factor that must bear on that issue is the availability of staff to deal with the problem, right?
Yeah, acknowledged.
The second reason that you proffer here at paragraph 121 is that the experience of the Ruby Princess was very fresh in all of our minds.
Yes.
I put to you, I think on Monday, that Ruby Princess was an event that involved COVID positive travellers just walking into the community effectively.
Yes.
That's not really the most apposite analogy, is it, in terms of what was going to happen here in terms of the options available? No one was talking about just allowing COVID positive patients from Newmarch House just to enter the community without any appropriate controls in place.
I think they were, in terms of transfer to another nursing home, classifying them as negative, and I think that is that had the potential really for, depending on how many nursing homes they were transferred to, it had the potential to be, you know, multiples of Ruby Princess.
So this was the decanting supposedly negative patients to a facility like Rooty Hill that was discussed for a short time. Is that what you're referring to there?
Exactly, yeah.
Right. But if, for example, another option that's been considered is transferring positive cases to hospital, then the Ruby Princess analogy just isn't apposite, is it?
I don't think that's applicable there, but I think there is a second issue that's applicable there.
Which is?
I think patient choice is the other side of what I was trying to achieve at that stage.
I'll come to that. That's a major issue, and I'm going to come to that in due course. The third rationale that's presented here, and it's dealt with in part at paragraph 121, but also back in paragraph 120, is that it was unclear who was actually positive and who was negative. And you had a concern that people who might be testing negative weren't true negatives.
I don't think we had separated the cohorts at that stage.
Now, the question I have to ask of you is this: first of all, does that bear on the issue of whether or not to move out positives?
I object to this. My friend needs to read those paragraphs in the light of the paragraph above 119, because that's what's referring to.
What's being put in the objection is that paragraph 119, if we just go to that, involves you responding to a suggestion that all residents that had not tested positive for COVID-19 be relocated.
Yes.
Now, one concern that you had was that those who hadn't tested positive may not actually be negative. That's right, isn't it?
Correct.
And I'm going to go back to the question that I asked you before the objection, which is, does that line of thinking, that concern, actually bear upon the circumstance of moving positive patients out of Newmarch House? That's a concern about the status of negative patients. But if you're a confirmed positive,
yes,
this concern doesn't apply, correct?
No, it does apply.
How does it apply?
It applies, and if you'll give me a little bit of time to explain, because it's something that I think if you define a positive group, by definition, you also define a negative group. And the negative group is really quite dangerous in that environment. Now, if you remove the positives out of that environment, this is the way I was thinking at the time. I'm not necessarily saying, I would do the same thing. But if you remove the positives out of that environment, infection control requires a lot of behavioural type thinking, and once people get the message that that group is negative, their infection control efforts drop, and you have an internal cohort issue. And I've seen this more recently in other nursing homes where we define cohorts. That negative group quite frequently then throws up new positives where the infection control requirements have not been done in anticipation of a new positive.
Are you saying that as at this time that you were thinking we could move positive patients out of Newmarch House, but that's going to leave a cohort that think they're negative when they might not be negative, and all the infection control principles will be relaxed?
Often not explicitly, but implicitly, yes.
But isn't that a matter that could be addressed by way of clear instruction and directions to staff and things of that nature?
There's a lot of staff involved, and behaviour is behaviour of a cohort of staff. Simple messages get passed one to another, and if the message is those patients are negative, I think you know, there is a risk there.
There are clear advantages, aren't there, with moving positive patients out in terms of taking pressure off the system?
I think on reflection and listening to all of my experts, then yes, I think is the answer to that question.
You also relied on the fact that, on the consideration that the movement of patients or residents could have adverse effects upon them.
Yes.
And allied to that concern was the concern that a prolonged stay in another facility, like a hospital, for example, or some other location, might also have a deleterious impact on residents.
I think we knew at that stage that there were going to be deaths associated with this group. Whenever COVID had spread in elderly comorbid patients, the mortality was high. I think what I would have done in an ideal world is a really, as my expert colleague said, a nuanced conversation about, you know, the possibility of death, and where possible, if the resident or the designated person had the ability to think that situation through and think, do I want to die in a hospital bed, or do I want to die in my own room if I am going to die? It might have been a choice we would have been more explicit with in hindsight.
You're talking about some type of advanced care planning discussion and consent-taking process.
Yes.
And the need to go to that level of detail.
Yes.
Again, I will ask some questions about that process because it's important. But just in terms of that rationale, that is that there was a consideration that moving patients effectively and moving them into a different facility might have deleterious effects. You had the opportunity to hear, in effect, the other side of the coin, which is that there were deleterious impacts that could occur and indeed did occur by leaving patients in Newmarch House. And you'll remember the evidence, for example, especially of Professor Ibrahim and Professor Kotsimbos about the fact that they're not in their familiar environment anymore because of the changed circumstances. What's your response to that evidence?
Well, my response to that evidence is I did see residents who had ticked that they didn't want to transfer to hospital, and some of them had very explicit instructions about how they would like to die if that situation was occurring.
Mm.
And we did have the opportunity to do that in their room in a way that was compassionate and dignified and consistent with their desires. Now, I'm not saying for a moment that we got it right on all occasions. We obviously didn't get it right on all occasions. But I am saying that there were occasions where patients were actually given the benefit of the doubt and given what they had put in their advanced care plan. And I'm not going to name the individual concerned, but I think you would know who I'm talking about.
You're talking about one of the 19?
Yes. Yes. But other patients as well. I think there are things, and look, I had the privilege of being...
When you say other patients, you mean other patients outside of the 19?
No, outside of the 19 and also within the 19, but not the one I'm referring to CA essentially.
Again, I'm going to come to the issue together about advanced care planning discussions and things of that nature. But just in terms of the evidence that's been given in this inquest, that while at one level, yes, there may be deleterious impacts of moving patients to a hospital, for example, there are real deleterious impacts with leaving patients in an environment of the kind that came to be at Newmarch. And you know what I'm talking about, the people, different staff, not the usual carers, wearing full PPE, which is something they hadn't seen before, being locked in their room, the disruption to the basic services they were receiving, disruption, family visits.
Yes.
Those problems were there anyway and could be better managed in a hospital setting. What's your response to that?
I acknowledge all of what you said is true. However, and we can speculate how this occurred, I think we got into a black and white situation. And I think the nuance was a hybrid, was a half-half.
I just want to understand what you mean by that answer. When you say black and white situation, do you mean...
Transfer all the positive residents,
Yes.
or transfer all the negative residents, or transfer the whole facility.
Rather than individualised care.
Rather than individualised
individual
care.
decisions.
And I think, on reflection, the point is well taken. And if I was doing this again, I would selectively, and I would try and still be selective, rather than have a blanket transfer all these or transfer all those. And I think that is consistent with some of the expert witness we've listened to over the last couple of days. I think that would be ideal in my view.
I assume that in that answer, when you're talking about a black and white approach, that also encapsulates a blanket admit everyone into hospital in the home model.
Yes, but again, I would highlight that my understanding of the admission to hospital in the home is not the understanding that I think a bystander would get to what we've heard up till now.
Right, because, all right, we'll come to that in a moment with greater specificity. But just to complete this issue about weighing the detriment of keeping people there in their what used to be a familiar environment and moving them to a hospital, for example. It would have been clear, can I suggest, from the size of the outbreak, pretty early on, this was not going to be a matter that resolved quickly within days.
I think there's more to a familiar environment than just the staff looking after you. And there are specific examples that go to that.
But the environment as they knew it was severely disrupted during the course of this outbreak. You must accept that.
I accept that the staff component of that would have been very disorientating. The staff component in hospital would have also been very disorientating.
But also movement through the facility. That changed radically, obviously, during the lockdown and the isolation of patients within their room, yes?
Yes, but they are being isolated in their home-like environment, and I think that is an advantage despite the staff changing. I think it's a different matter, and I really do feel that didn't apply to one patient in particular who was moved to a more difficult room for her emotionally, and I feel for that patient and her family.
Right. We understand who you're talking about there. Just coming back to my question, it would have been known or anticipated, maybe that's the better word, it would have been anticipated this outbreak at Newmarch was going to take some time to bring under control, just given the scale of the outbreak. Yes?
Yes.
And that entailed that the likelihood is residents were going to be in that environment, that isolated lockdown environment, for some significant period of time.
Yes.
Weeks.
Yes.
So clearly that was a countervailing consideration that had to be thought about.
Counter to how long they were isolated in hospital,
Yeah.
Yes, but with patients that we subsequently took from nursing homes to hospital, there was a prolonged reluctance to accept that patient back into the facility after their hospitalisation. So many patients, once hospitalised from a nursing home, would stay there for a prolonged period of time, acknowledging that they can get physiotherapy in a hospital environment, etc.
Do you remember what the reason was?
What the reason
Was for the reluctance to take patients back into the home?
because of COVID fear.
Safety, wasn't it?
Well, it comes to the clearance of COVID, which is another issue I'm sure we'll get to.
Weren't voices saying in meetings on subsequent occasions when two particular residents had been transferred out of hospital, their cases came up for discussion. There's no way these people are going to be allowed back into this particular environment. It's just not safe. Isn't that what was being raised?
Equally, for at least one of those, she was desperate to go back and was caught in a quite distressing emotional situation where she wanted to be back in the facility.
This is a person who survived.
A person who survived.
The last aspect of the reasoning here is at paragraph 124, there seemed to be no clear plan as to where these residents should be relocated. So that's the point you made earlier in your evidence. You didn't think there was sufficient detail in alternative proposals being put forward.
Correct.
Right?
In fact, if I can remember an expression I used at the time, which is, I would like to look at the granular detail of what we're proposing here.
Right.
And we asked for that.
But look, it wasn't a situation, though, was it, that it had to be provided to you on a plate in granular detail. If you had an open mind about these things, you could have helped work towards those details.
It wasn't me making the decision. Why was I the decision maker in that space?
Right. Do you say you didn't make a decision about...
There were four major organisations involved. There was Nepean Blue Mountains LHD, there was the Commonwealth Government broadly, and the Commission lumped in there. There was Anglicare, and there was the PHN. And
to be fair, I put to you that on the 17th of April, that there was a consensus position reached effectively to move forward with your model. Right? Your role in this process is that effectively you proposed the model that was adopted. That's right, isn't it?
That's right.
And advocated for it.
Yes.
But what I'm putting to you is, and I don't want to traverse over this territory, the hard territory we've been over about what happened on the 16th and what people were thinking. There were other options being put up. You say not with sufficient detail, but it was open to you to engage constructively in respect of those options if you wanted to.
With due respect, I do think I did engage constructively. I've admitted on that occasion I found that an unproductive meeting. But there were many, many meetings during the subsequent time, and I believe and sometimes I had to, bite my tongue and engage, very deliberately, constructively. But I think that was a successful collaboration.
That it was a successful collaboration with the other government departments. Is that your evidence?
As the situation matured, and we're going to get to the timeline soon where things changed.
In your reasoning about the appropriateness of the course that was taken, did adequacy of clinical care that could be provided at Newmarch House feature in your thinking?
Yes, and once again, perhaps too naively, having listened to the experts, and we were dealing with a new virus, a highly contagious virus, a virus that had no treatment, no antivirals, no immunosuppressive agents, and we only had supportive care.
What's the naivety?
The naivety is to the extent of what can be encompassed in supportive care. I guess I felt at the time that we could provide all of the things that were listed in supportive care. Frequency of OBS that we've heard a lot about, or things are holes in my argument. And they weren't foremost in my mind at that stage. And I did discuss this with my infectious diseases colleagues at the time at Nepean, and the general feeling was consistent with what I was saying, that care was very similar in hospital to what we could deliver in Newmarch.
And your view now?
My view now is that there were some crucial things I didn't take into account there, like rapidly getting the nursing and medical care to the level that it needed to be. And for the second half of the outbreak, we did do that. But in the first half of the outbreak, I think second half, I don't mean the entire outbreak, I mean, when there were a significant case burden. But I think we got there. We just got there slowly.
When do you think you got there?
It's a good question.
How late into the outbreak? Certainly wasn't there by the end of the first week, was it?
I think the turning point, I think the two turning points were the insertion of doctors, which didn't occur.
You mean general practitioners?
Yeah, one was a general practitioner, one was a general physician, but we had an agreement that the PHN would supply doctors from quite early on.
You're talking about that shift in approach where the residents were taken off the hospital in the home program and then readmitted as outpatients that particular moment, so the GPs could start billing? Is that the time?
No, that was irrelevant. The billing is a red herring.
Just tell me what the time is that you're talking about.
When the two locums went in there, locum GPs, late April.
24 April.
Might have even been later, I think 28 maybe.
Sorry, I'm being told 30 April.
30, yeah.
Right. So that was a turning point?
The announcement came out 28th of April, but we had been waiting for a couple of weeks for that to arrive. We'd been asking for that from the outset, and it was frustrating that it didn't happen.
Right, that's 30 April. What was the other turning point that you mentioned? You said there were two.
I think Melanie Dix and the Baptist Care taking over the management of the control room gave some calm and some clarity to what had been a very panicked situation prior to that.
That's 24 April.
24 April, yeah.
All right, so things started to turn around between 24 April and 30 April is the evidence, right?
I think things turned around from the 20th of April.
Well, that in the sense that the 20th of April was the absolute nadir of the crisis, right?
Yeah, correct.
These are hard statistics, obviously, to deal with, but as at 24 April, there were 32 positive cases amongst the residents, And by the end of that day, there had been 5 deaths already, right? By the 30th of April, 37 cases, which is the maximum number of cases. That's the peak of the spread amongst the residents. And by that stage, 13 deaths had occurred. So while the team was getting things right, the consequences were already unfolding, weren't they?
Well, and if I could use this opportunity to express my sympathy to the families, and please forgive me if I talk scientifically about what are really quite emotional issues for the families and loved ones. I guess we've always known that cases will have a parallel death curve, or not a parallel, but a subsequent death curve associated with it. The most useful measure we had to prevent death at that stage was to prevent transmission. And it was with great sorrow that I think we had a transmission event on or around the 20th because of the issues that I've highlighted in my statement.
Can I suggest to you that one aspect of the approach that you took, and we've gone through the justification for the approach, was that containing the spread within the facility was given a great deal of emphasis.
Yes.
And a corollary of that is that the level of medical care that was provided to the residents within the facility was given less emphasis in the model.
I don't think that was by design. I acknowledge that that's the way things panned out, but it certainly wasn't by intent.
The intent or the design was that there would be an insertion team of the kind that you've described, which had multiple capabilities and capacities,
yes.
Right? The intention was that there would be, and tell me if I'm wrong about this, a regular medical presence, either in the form of a VAX team.
The regular medical presence, right from those early meetings, was a request for 2 doctors to be in the facility all the time, looking after COVID negative and COVID positive patients.
And you've indicated that didn't occur till the 30th of April, and you've also indicated that you're requesting that for some time.
For some time, and being assured that it was going to occur.
What I'm asking you here is you mentioned it wasn't the intent, wasn't the design. I want to just get at what the expectation was in terms of the level of care that would be provided.
The expectation was that HIF would be coordinating the monitoring.
Yep.
And VAX would be coordinating the clinical care on the ground in association with 2 doctors in the facility. So that was the expectation.
Just in terms of that expectation and what we now know happened, is it fair to say this? HIF were not able to effectively fulfil the role that you've just described, largely because of communication difficulties and difficulties in obtaining information in a timely manner.
Correct.
The insertion of the 2 doctors that you refer to didn't occur until the 30th of April, well into the outbreak.
I was under the impression it was about to occur constantly, and I did keep asking.
Who are you asking, by the way?
Essentially the PHN through those meetings that were occurring.
PHN standing for Public Health Network.
Primary Health Network.
Sorry, Primary Health Network.
Primary Health Network. And I guess it was an expectation that there was an expression, we're all in this together back then, and I had the expectation that if we requested 2 doctors, there are 150 GPs in the area, we'd be able to get 2 that came in. In fact, I even negotiated with the Commonwealth for a novel funding arrangement for them. And Michael Lai was very quick to agree to it.
So what was the hold-up from your perspective?
I couldn't understand it. I could not understand it.
Something went wrong, and as a result there were delays, and those resources weren't provided until the 30th of April. Does that summarise the position?
There were no doctors prepared to come into the facility and help.
Right. And what is the basis of that understanding?
The basis of that understanding is, I believe, the Primary Health Network had a meeting of all the general practitioners in the area, and a request was made, and it was felt that they couldn't help due to being unable to leave their practices, and that's entirely understandable. But the solution that eventually came was to go to a medical locum agency and hire 2 doctors to come in and help.
Who provided you with this information about discussions in the public health network and the reluctance of GPs to be involved in the way you've described?
Yeah, the Primary Health Network and discussions with the Primary Health Network. And I believe, I was being updated in these meetings on a regular basis. And we had a meeting last night, and this was the view from the general practitioners.
You're talking about the high-level meetings between the different...
Yeah, I think so. The 4 pillars meeting.
And then the last ingredient in the expectations you described was the level of intervention that VACS would perform. Right? That was the third factor you referred to, that VACS would be monitoring, and I just want to get the language right.
So HITH were, in my mind, HITH were monitoring, VACS were providing clinical care on the ground, and in the latter part of the outbreak, the insertion locums worked very well with HITH, was what I was seeing, and were really important to a lot of the teleconference work they were doing in a latter stage. So there you had 2 locum doctors seeing patients, allied health seeing patients, VACS reviewing things with both teleconference and on the ground.
Well, let's just focus on VACS. We're talking about this third item.
Yeah.
What was your expectation about how often VACS practitioners would actually be present on the ground?
It was dependent on what we had with other people on the ground, I guess, with the locums. So I think once the locums came in...
Assume that we know the locums didn't come in until the 30th of April. What was, in that context, what was your expectation about how much time VACS practitioners would be spending on the ground, given that it is a virtual aged care service and is designed to operate remotely?
It's a virtual aged care service, but they were on the ground.
Right. What was your expectation about how often they should be in the facility?
I never formulated a figure.
Did you need to think through that level of detail if this plan was ever going to work?
Yes, that's a fair point.
I want to briefly ask you some questions about the HITH policy and guidelines. Now, I anticipate that the evidence that you're going to give is that it wasn't the case that a pure HITH model was applied here, right?
Correct.
Nevertheless, the HITH program had been established for some time in your local health district, right?
Well,
and in New South Wales.
I think one of the pities, one of the things I did wrong was to use HITH as the expression, because we've always known it as the Nepean Outreach Service. That's been the name of that service for a lot longer than HITH. So,
But that is the term that you used. That's the first point.
yes,
And you used it in meetings with health professionals,
yes,
right? So they are going to receive those words and give them the meaning that would ordinarily be ascribed to them. That's what you'd expect, isn't it?
yes.
If we can just pull up quickly, I'm not going to go through these policy documents in any great detail, but I just want to point out some aspects of them. Tab 3 of volume 26, please. And if we could go to page 16. We can see that next to, under the word context, it says this: New South Wales Health defines hospital in the home, HITH, as a clinical model that provides admitted, acute or subacute care in the patient's home or the community as a substitute for in-hospital care. Instead of receiving care and hospital accommodation, patients receive hospital-level care whilst being accommodated in their own home.
Yes. So
clearly, and we've heard this expert evidence given about this, this is a substitution program which is designed to provide hospital-level care in particular circumstances.
I'm just looking at the document that's being read from. It seems to be dated 10 August.
5th of August.
Is it the case that prior to this particular policy being drawn up, that there was a version in place that had been drawn up for the paediatric context? Just remembering your evidence from the Royal Commission. Is that right?
I remember that, but I can't remember.
And that this was in draft at the time, this particular policy?
HITH policy, was it, or?
The HITH, Nepean Adult HITH policy.
Nepean Adult HITH policy. Sorry, the question?
That this was in draft at the time. Is that the case?
I can't remember.
Did you, let me short circuit the issue, did you review a policy document concerned with HITH prior to the 16th of April?
Immediately prior to the 16th of April.
In that time period?
Probably Professor Sood would have reviewed it, I would imagine.
I'm asking you though, were you familiar with what the policy was in this particular area?
Yes, but I wouldn't have been overly focused on policy.
And is the reason that you wouldn't have been overly focused with policy because you didn't actually think you're applying a HITH model as it was commonly understood?
I don't think we had a written model of exactly what we needed to do in this situation.
At any time, did you go through a policy document in relation to HITH to look at things like its objectives, eligibility criteria, exclusion criteria, things of that nature?
I think I was aware that there was discussion going on, and I was aware that other hospitals were using versions of HITH in ways to do COVID work. And I think everyone was exploring that space.
Was there a policy document in place at Nepean about the operation of HITH as at 16 July 2020?
Yes.
What was that policy document?
I'd have to go and find it.
Can we go to page 1 for a moment? Was it a document that looked like this?
Okay, I've seen the document.
Do you recognise that?
They all look pretty much the same, to be honest.
All right. Well, was there any discussion amongst your colleagues about the eligibility criteria and exclusion criteria for hospital in the home?
Yes, we meet in hospital in the home 3 times a week. So we run our department out of hospital in the home. And in many ways, hospital in the home and infectious diseases at Nepean are synonymous. So me and my colleagues would have been meeting Monday, Wednesday and Friday in hospital in the home seeing patients.
From your knowledge, as someone who had worked extensively with the hospital in the home model, did you understand that this was a model of care that was available to patients in the Nepean hospital catchment area? That's the first point.
Yes.
That it required that there be a primary carer who was willing and competent to provide care in the home environment where required?
Yes.
Telephone access was required.
Yes.
Patient had to consent to receiving hospital in the home treatment at home for this model to be used.
Yes, but not written consent.
No, but consent, I didn't say written consent. Consent was a requirement.
Yes.
There was a requirement also that the environment in which the hospital in the home model was delivered had to be safe.
Yes.
In terms of exclusion criteria, was it your understanding that patients who declined the service, in other words, didn't consent to it, would be excluded from it?
We wouldn't put people on hospital in the home if they said we didn't want to be on hospital in the home.
Right.
That's often once they're already inpatients and then they don't want to go home on hospital in the home.
Yes.
So it's often a post-acute care.
And further, that patients or families who have indicated that they are unable or not prepared to look after the patient at home during the acute episode of illness would also be unsuitable and excluded. Now, can I ask that volume 26, tab 1 be brought up, please? Now, this is a guideline document, Adult and Paediatric Hospital in the Home Guideline, publication date 9 August 2018. It's a 57-page document. I might just ask, for example, just to go down to the first page, the next page, I should say, just to give you a sort of view of it. Is this a document you've seen before? This is a New South Wales health guideline.
Yes.
Now, as we understand it, while policies were mandatory, guidelines were not. They're guidelines. They provide guidance, right?
Yes.
Was this a document that you were familiar with at the time of the Newmarch outbreak?
Yes.
Can I ask that we go to page 15? And if we could just read at 5.1. And was that your understanding of the guidance in place about when HIF was a suitable model to use?
For paediatrics.
For paediatrics. This is a guideline that applies to both adult and paediatrics. If you look at for example, the top of the page,
Oh, okay.
it's not just a paediatric guide, but just looking at those key elements. You want the same type of staff, skills and knowledge provided as if the patient were in hospital. Patient should be clinically stable, safe to be treated in the home environment. It's regarded as an acute or subacute short-term service.
Yes.
Those key principles, did you understand them as applying to the hospital in the home model?
Yeah, sure.
Then over the page, page 16, please. If you can just look at the patient selection section, to be suitable for hospital in the home treatment, a patient must, I'm not going to go through every point, but the second point, consent.
Yes.
Not require 24-hour assessment, treatment or observation. Continuous 24-hour assessment, treatment or observation. Be competent in managing their condition, or have a live-in carer who takes that responsibility. There's a reference also to having a suitable and safe location for care outside of the hospital.
Yes.
Do you understand that those principles generally applied?
Yes.
The next, just going down to about 2 paragraphs under those dot points, the admitting clinician should fully inform patients and carers of the benefits and risks of the HIF. Patients should have the opportunity to decline this service if they prefer.
Yes.
That's providing real guidance in terms of the consent requirement.
Yes.
Do you understand that applied?
Yes.
And then finally, down the bottom of that page, exclusion criteria, patients may not be eligible if they're medically unstable. You see that there? It's not being shown. Sorry, it's bottom of page 13.
I'll accept whatever's in the document.
Right. Just over the page, they may not be unsuitable, second dot point, if they require complex care that exceeds the capacity of the HIF service. Do you see that there?
I'll accept it.
So I've drawn your attention admittedly to selective aspects of a very large document, but just on the face of it, those considerations that I've taken you to, put aside the issue of consent for the moment, because that's a separate issue we'll come to, those considerations were not going to be fulfilled in relation to the application of a HIF policy in this particular context, Newmarch House, were they?
No. So...
You're agreeing with me?
I don't think that document fits what we did at Newmarch House.
Yes, that's probably a more efficient way of putting what I was trying to put to you.
Yeah. But on the other hand, I think we faced a terrible situation. We had to look at the tools we had available. And those tools weren't perfect, so we tried to improve them. And we improved them with a model, as you pointed out, that wasn't a highly refined, developed model with a policy behind it that was appropriate to what we were trying to do.
Well, I think more than it not being highly refined and developed, I think the effect of your evidence is that the implementation of a hybrid model of the kind that you're talking about on a scale of what you had to deal with at Newmarch had never been attempted before. This was new territory.
On that scale, yes.
You also had the guidance of the ACID guidelines, the Australian Society for Infectious Diseases. That's something that you raised in your evidence on Monday.
Yes.
We've since been provided with those guidelines. These were specific to COVID-19 patients, guidelines for the treatment of COVID-19 patients, although it has to be said, not specific to residential aged care facility context, right? But those guidelines indicated, first of all, where possible, patients with a provisional or confirmed COVID-19 diagnosis should be managed out of hospital, either at home or in a step-down facility as per local jurisdictional policies. So the starting point was manage out of hospital. But then the guidelines provided very specific guidance about when you would consider admission to a hospital, right? And that included consider admission, if any, of hemodynamically unstable, hypoxemia, in parentheses, oxygen saturation on room air less than 94%, reduced platelet count, comorbidities, or unsuitable home environment. That list that I've just read to you from the guideline, many of those features were present in respect of the patients at Newmarch House, right?
Yes.
So what you have here, when you look at that policy or guideline setting landscape, is that it's not the case that the guidelines were saying avoid hospitalisation at any cost. Clearly, that's not what they're saying, right? There are programs that are available for treating people in the home under particular circumstances, right? When there was, and that includes when there is consent and where the patient is eligible, right?
Yes.
You've already conceded that the eligibility and exclusion criteria don't really fit what happened at Newmarch House in respect to the hospital in the home model.
Yes.
The ACID guidelines, ACID, set out indications for when hospitalisation is indicated, right?
It sets out guidelines for when they should be considered.
Well, I still press the question.
Yes.
I object.
Yep. Sorry, just a moment, Doctor.
Sorry. If my friend wants to use a guideline, I have a distinct recollection of this being suggested to me yesterday, he ought quote it accurately. The word is consider.
I read it.
Not in that question, you didn't.
No, I didn't in that question, but I read it first to Dr. Bradley, and I'm now putting a different proposition to him, whether in his mind he is of the view that this guideline provided guidance about when hospitalisation was indicated in a COVID-19 patient. And I understood Dr. Bradley agreed with that proposition.
All right. Well, for the purposes of the objection, I understand the distinction. I allow the question. You can answer, Dr. Branley.
What was the question again?
I'll read the guideline. Consider admission, if any, of hemodynamically unstable, hypoxemia, oxygen saturation below 94%, reduced platelet count, comorbidities, unsuitable home environment. Right? Is this document providing guidance about when hospitalisation is indicated?
Yes.
Now, we know that the vast majority of the cases from Newmarch were not hospitalised, correct?
Yes.
You've heard evidence from multiple experts now about the potential benefits of treatment or care in a hospital setting.
Yes.
And can I suggest to you that there was strongly consistent evidence given by experts like Professors Katsimbos, Curl, French, Ibrahim, and in written form Dr. Roth as well, to the effect that a level of care afforded at Newmarch House was not equivalent to the level of care that would be available in a hospital.
For me, the word equivalent, medical care, yes. It was not equivalent. But I think there were other benefits to being in that environment.
Can I drill down and be a little bit more specific? Can I suggest that the consensus that comes out of that body of expert evidence that's been given in the inquest is, first of all, that there was superior efficacy of supportive treatment in a hospital environment?
I think in the second phase, we did have equivalence.
You're talking about from 30 April onwards?
Yes.
So at least up to 30 April, you accept that hospital standards in terms of supportive care were not present at Newmarch House?
I think there was supportive care that was present at Newmarch House that wouldn't have been present in hospital as well.
Right, certain things that could be offered there.
Well, emotional supportive care to a certain extent, being able to look at photos of your great-grandchildren, being able to play the music that you want. Views out onto the garden, being able to have visits of your family. I think that's all supportive care.
That may be right, but there was very detailed evidence given by the experts, and I don't think we've got time to review all of that evidence, about the types of resources and facilities that are available at a hospital to ensure a higher level of supportive care, such as...
So in the early phase, I would agree with you.
A hospital has the advantage of the availability of more active forms of treatment, if warranted. You agree?
Yes.
There was the capacity within the hospital to escalate treatment quickly, if that was needed.
Yes.
There are also advantages to the patient in terms of comfort and palliative care, if that was the path ultimately taken in the hospital.
I would say that Newmarch was considerably better than what I've seen in the hospital for many of the residents who died.
In terms of the palliative care aspect, is that what you're saying?
Yes.
From what date? When do you time that? And just by way of a marker, just hold on a second. What are they doing up to? Yeah. Palliative care came into video conferencing from the 24th of April.
I think...
So that's already 13 days after the outbreak started.
Yes, but I think the dying experience might involve palliative care, but it might also involve dying comfortably in your own room.
Right.
And I think there were examples early on what I saw of that occurring.
Right. There are also other experiences that have been the subject of evidence.
Clearly.
Quite distressing evidence.
Clearly.
Particularly on the part of families. And do you accept that in very large measure, the standard, withdraw that, in the majority of cases, loved ones were not able to be physically with their relatives, were not able to be physically present with their loved one when they passed away?
Yes, but I don't think that's a difference with hospital.
Right. No, but I understand that you're talking about the advantages that the home had over hospital.
Yes.
I'm putting to you effectively
yes,
that
I'd agree with that.
it wasn't a situation where the home allowed, because of the circumstances.
Unfortunately.
Having heard the expert evidence about the benefits of hospitalisation and noting the concession that you made earlier in your evidence about having heard that evidence and it having an impact, are you prepared to concede that there were, particularly in that period up to 30 April, advantages to patients in terms of hospitalisation?
Yes.
Now, I put to you that, and took issue with this to some extent, that there was a blanket admission process into the hospital in the home model. And just to give context to that, first of all, are you aware that every single one of the 19 patients was admitted into the hospital in the home program in the first instance?
Yes.
Now, could this document be brought up, please? Volume 1, tab 15, page 2. So this is an example of the health notes, the progress notes that we have from Nepean Hospital, which were taken by the hospital in the home team. If you go to page 1, perhaps, just to give you the context, you can see that that note starts under the heading HIF. This one relates to Mr. Jennings. And what I want to direct your attention to specifically, this is the first entry, is on page 2. Under plan, thank you for that, it says enrol in HITH as per new protocol for HITH COVID-19 Newmarch House residents. Await aged care facility to send us update advanced care planning. Now we see entries like this right through the medical records for patients. Doesn't that accurately describe what was happening here? People were enrolled in HIF, what was understood to be a HIF program, as a matter of course, as per a protocol. And then, and only after that, was the advanced care planning update sought.
Yes, correct.
Now, that approach doesn't indicate, at least at the level of admitting people or enrolling them into the HIF program, that there was anything like a case-by-case analysis going on.
No, but parallel with that, I had really early on approached VAX and asked them to do a parallel piece of work to determine what residents wanted, or to try and determine what residents wanted. And I know it was a flawed process. Flawed.
Yep.
But we were cognizant of that, and we tried our best to address that issue, and we didn't do it as well as you would in normal situations.
What time period are you talking about there?
I think first day, like 14th.
This. Isn't the process that once they tested positive, they're automatically enrolled into the HIF program, as
Correct.
a document like this would suggest?
I'm not saying that happened in the right order.
And then VAX would come into the picture as part of the process of delivering care under that model, and part of their role was to provide updated advanced care planning.
Well, we're saying the same thing, I think.
Right. But you're saying in any event that, I think what you're getting at is, in your mind, what was clearly important was that there was then an advanced care planning discussion at an early point in time.
Yes, and
your expectation was that VAX would be doing that?
yes.
And what you appear to be conceding is that those conversations weren't held in the manner that you would have liked.
Well, I don't think we did it sequentially in the order it should be done according to policy or whatever, but we made the best efforts we could to actually try and find out what residents wanted and what were their desires in this situation. And we did have a view that we wanted to uplift and selectively transfer patients when there was an indication, and when the patient was consistent with the patient's request.
I'll come to the flowchart in a moment, But do you agree at this, just at a level of principle, that given that this approach was taken to enrol the patients directly into the hospital in the home program, that really what became critical was that there were advanced care planning discussions conducted in a timely manner? That's the first thing.
Yes,
Second of all, what's critical is the quality of those discussions, right?
I agree.
Consent has to be informed consent, correct? And you need to have a conversation that will allow informed consent to occur. Do you agree with that?
I agree.
Otherwise, the whole consent process is vitiated, isn't it?
And
Can I
it's
suggest?
a great disappointment to me because my model in my mind was that this was individualised care and we were focusing on the individuals. And the fact that we didn't do that with nuance and sensitivity and actually get it right is disappointing from my point of view. I think we made efforts to do it well, but I think that the time and the fear and the toxicity of the environment with the press and the drones and the helicopters and whatnot made those discussions progressively very, very difficult.
Yeah. And I'm going to come to that toxic environment and the difficult environment in a moment. But before I do you agree that the minimum requirements of a proper advanced care planning discussion in this particular context was, first of all, that there be discussion about available treatment options,
Yes.
that the benefits and disadvantages of those respective options be explained,
Yes.
that there be realistic and accurate information provided to patients or their families about the capability of a particular option actually being delivered.
Yes.
And what that meant is that given that one of the options was transfer to hospital, there did need to be a discussion about the benefits of hospitalisation. Do you agree?
There needed to be a discussion, yes.
There needed to be a frank assessment of the capacity of Newmarch House to provide the level of care that was intended.
Yes.
If there were particular problems that were becoming clear, they had to be frankly raised with patients and families. Things like staffing shortages, absence of medical practitioners on the ground, those sorts of circumstances needed to be spelled out if they were known. Do you agree?
Yes.
Were you involved directly in any of these conversations with patients?
I did see some of the patients early, and I tried to get a sense from them as to their views and as to their level of comfort, but I can't remember those conversations terribly well.
I mean, can you say that you ever had a conversation of the kind that I've just been putting to you as the type of conversation that should be happening, that level of conversation?
In an ideal world, and this argument applies to palliation as well, you have everyone present. You have the elderly resident who may have a degree of cognitive impairment.
Yes.
You have the family and the designated person, and you're not wearing masks, and you can read the body language of each of the people. We stood no chance of doing that in this environment.
Right. But were you here when Dr. Dharmaratnam gave evidence?
No.
Right. Can you take it from me that he was a doctor who was tasked with having some of these advanced planning discussions? And his evidence included the following, that he understood that hospital transfer was not an option and that apart from intubation, CPR, life support, all other treatments were available at the home. And that those instructions fed into the conversations that he had about advanced care plan. Now, hearing that, you accept that that is going to lead to a situation where, in effect, a patient is being informed that they really don't have a choice.
I'm disappointed to hear that the plan went down that pathway.
And I should add that there's been evidence from a number of family members in this inquest to the effect that they felt pressured or that they didn't feel that they had a choice. Evidence of that kind.
I find that disappointing, and I apologise to the families for that.
I mean, clearly that type of situation should not have occurred. Do you agree with that?
I agree.
And can I ask you this? Is there a disconnection in your evidence in the sense that at one level you're promoting a model, including at high-level meetings, which was ultimately, by consent, proceeded with, the consent of the various stakeholders in the process at government level. But on the other hand, not being involved directly in this critical aspect of the model, which was so fundamental to its success.
If I had my time again, I would have at least more specific writing instructions as to how that was to occur, I guess, even if I couldn't physically do those discussions myself.
I've got to finish up this evidence so that my learned colleagues have opportunity to ask questions as well before we finish today. So I'm going to try and move through as quickly as possible this last part. Could I ask that volume 26, tab 13, be put up on the screen, please? This is a document that we understand is a flowchart type document that was brought into existence during the outbreak to explain the process by which the model would operate. Have you seen this before?
No, I don't think I have.
You don't recognise the first page?
I don't recognise this document.
It might be that there are different aspects to it. Can I go to the second page, please? Do you recognise that?
I recognise that, yeah.
If we just scan to the bottom of the page, is it your signature on the left?
I think so.
Do you know when that signature was affixed, or you're not sure?
I think when, for the Royal Commission, probably.
It might be as part of the evidence gathering process in a proceeding, you're asked to sign an annexure to a document.
I wouldn't normally sign a document.
Right, so we can take it that that signature wasn't applied as some sort of approval of the flowchart. But your evidence is that others in your team, and I think you identified Dr. Sood as being a key participant, drew up the document.
Yes.
With the involvement of Dr. Sharma, was your understanding?
It was my understanding, yeah.
And that you approved the document?
Well, I approved of what was in the document, yes.
Right.
Can I just make something clear? Are you referring to the 2 pages you've gone to as one document, or are you simply dealing with the second page?
I'm just simply dealing with the second page at the moment. Dr. Brownlee indicated he didn't recognise the first page.
Yeah, because they've got different numbers.
Just in terms of this flowchart, can I just draw your attention to aspects of it? Do you see the first arrow there on the left deals with laboratory results?
Yes.
The second arrow deals with what happens if the patient is medically stable.
Yes.
Admit to hospital in the home. Observation should be taken twice a day. daily phone calls by the hospital in the home nurse, along with VACs, to check on wellbeing and observations. And then the fourth point, VACs team to ensure advanced care plans for all positive residents.
Yes.
And you've given evidence about whether some of those expectations may not have come to fruition. And I won't go over that again. What the policy then, the flowchart then refers to underneath is that the palliative care team was to be informed by VACs of the advanced care plan, and PRN medication to be charted for individual patients, residents through the VACs team, and crisis medication packs to be made available. Do you see that there?
Yes.
So what the process seems to envisage is you, one, admit into the hospital in the home. You have a high level of monitoring and observations being conducted, and you get advanced care plans in place. All right?
There's another page that...
Yes, I'm going to come to the next page. This is for medically stable patients that we can see. That's what the arrow says. It also appears to be that even with the medically stable patients, that the palliative care team is to be involved through VACs, by being informed of advanced care plans and crisis or anticipatory medications that are to be charted and provided. Looking at that last section of text at the bottom of the page.
Right.
Now, can we go to page 4? Page 3 is an identical page, or substantively identical. Then you go to page 4, which is what happens when the patient becomes unwell. You see the red arrow?
Yes.
And the markers there that have been set out are escalating temperatures, shortness of breath, and oxygen saturation below 93%, right? Which were clearly features that were present repeatedly amongst the residents at Newmarch House.
Presumably as well, you know, if consistent with their advanced care directive.
Mm. So in the event of a worsening patient deterioration, the facility is to consult the advanced care plans for the patient. So the facility is Newmarch House, is that right?
Yes.
And then, if the management within the facility, VACS gets contacted, palliative care team is contacted by VACS, and that's the guidance that's provided at that level, right?
Yes.
If for active treatment, then the facility calls Nepean Hospital. If we go over the page, if it's within hours, the facility then, or the facility as part of contacting the hospital, contacts VACS as the first point of contact, and if unable to get through to VACS, calls the Infectious Diseases Department.
Yes.
If it's out of hours, they call VACS on a particular number. Do you see that there? And VACS consults infectious diseases on call before any decision to bring patient into hospital. So this is where a patient is actually asked to be transferred to hospital.
But that's to do with managing that transfer process.
Right. I was going to ask that question. What was the point of that intermediate consultation with infectious diseases? This is about managing the transfer itself.
Yeah, I mean, the same thing happens in HIV patients with COVID in the community, is that you want a call so that you can actively manage the infection risk of the transfer. That's what that's about.
Right. Then it says this: if deemed appropriate, patient to be brought to ED via ambulance. What does it mean, if deemed appropriate?
Well, if it's consistent with the Advanced Care Directive and the patient wants to come to hospital.
Well, can I suggest we're past that point, because we're only in this part of the flowchart if the Advanced Care Directive has indicated that the patient wishes to have active treatment. And that's why I'm asking, that context, what does it mean if deemed appropriate? Who deemed whether it was appropriate? Whose decision was that?
I don't read it that way. I read it as, if all the evidence has been looked at and it's deemed appropriate that the patient come to hospital, then they come to hospital.
Sorry, so you think the words "if deemed appropriate" means it has already been deemed appropriate?
Yes.
Well, who's deemed it appropriate? Who's made that decision, according to this flowchart?
Well, I guess it's the the summation of all of the above.
Can I suggest to you, without spending a great deal more time on this document, that there's a level of ambiguity in the document?
I would agree that it's not a perfect document.
Just in terms of the process of the questions and the answers and trying to interpret it, doesn't that sort of bear out that it's not a clear document when it comes to the choice of hospitalisation?
I think it was hastily drawn up, and I think it had a revision pretty soon after that, didn't it?
Oh, this was superseded. Is this what you're indicating?
The more recent one had the hub in there as well, which I haven't seen in this one. But
well, if you look underneath, it says, under if deemed appropriate, patient flow hub to be contacted.
Okay, this might be the second one then.
Right. That's the reference to the hub you're referring to?
Yeah, I was looking for that, sorry.
Can I suggest to you, and you've already indicated that you take responsibility, that's one thing, that's taking responsibility as a leader for aspects of what happened, but just directing you to a different issue, which is whether there was a clear process in place, a clear chain of command. Do you accept that?
You read my statement. One of my concerns in the statement.
Quite. That there wasn't. And
at all sorts of levels.
And at one of those levels was, it wasn't clear who had ultimate responsibility for treatment decisions of patients.
I think that's a fair criticism.
And it wasn't clear who had ultimate responsibility in terms of a decision to escalate treatment or not.
Yes.
Okay. What we can see here, and clearly with the benefit of hindsight, is that what was being attempted was to implement what is a complex model. It's not straightforward by any means, is it?
No.
A complex model in a system under strain.
Yes.
And if that was ever going to succeed, there needed to be really clear and open lines of communication.
Yes, however, can I highlight that thinking at the time also was that Newmarch House was the first of several. We were expecting multiple nursing homes to have similar problems, and I guess we were trying to work out a system that could be refined, and ultimately, this very early work led to the system that we have now, and it's not all that different. It's just that the players function differently within that.
You accept that that may not bring a great deal of comfort to the families of
Absolutely.
those who passed away at Newmarch House.
Absolutely, but we were trying to implement something that we thought would be robust and would work.
I'm coming to the end of my examination, and I want to ask you about this.
Yeah.
Clearly, you've accepted there were moments of great strain, and you've highlighted 20 April.
Yeah.
Can I suggest 18 April was another day involving significant strain as well?
I'll accept that from you. It's not something that is in my memory.
On 20 April, I'm just referring to your statement, paragraph 132, you talk about a crisis in staffing, which culminated in insufficient staff being present on that day, particularly in terms of registered nurses.
Yes.
Care and infection control, these are your words, were severely compromised on that day due to the overwhelming workload.
Yes.
And that included seeing one or two patients wandering within their ward, just reading from paragraph 145 of your statement.
Yes.
And also some fomite breaches due to time and staffing pressure.
Yes.
And there's been evidence, and I think I've even asked you this, put this to you earlier, that on that day you had to attend to the personal care needs of particular residents because there just weren't other people on the ground to perform those functions.
Yes.
Right. That was on the 20th. Residents had started, the first death was on the 18th. So the fatality started on the 18th, 2 days before. That was Mr. Jennings. And we know that the fatality count then just started to inexorably progress as matters went on, right? Given the strain that you saw in that first week,
Yes.
particularly in that period around the 18th to the 20th, wasn't that a time where you might have considered a change of approach?
It certainly was a day where I not only considered a change of approach, but I requested a change of approach.
What was the change of approach you requested on that day?
I didn't specify, but I said it's not working and, we need to change.
Right. Do you know who you made that request of?
Well, I heard Christine's view of it, Christine Giles's view.
She wasn't in a position to make a
No,
decision about this. She was managing or assisting in the management of the facility.
yeah,
And she's given evidence about a conversation with you where you said to her around that time, things are deteriorating at Newmarch. I think that's my memory of what she says in her statement.
so I think for memory, and my memory is cloudy, but I did request that HIF come down and help physically. And I also had a conversation with David Goodhue.
From Anglicare?
Yes.
And the conversation was what? To what effect?
I think something like, I'm not happy with the standard of care. We need to do something different.
Was it within your authority? You accepted you were, if anyone was entitled to the title lead clinician, clinical lead, sorry, it's you. Were you in a position to say, this isn't working, this system is under strain, this is not what I envisaged, let's get these positive cases into hospital?
Just before he answers that question, could he be allowed to finish the answer that he was giving before he was interrupted?
I'm sorry, I thought Dr. Brownlee had finished the answer.
No, I hadn't. I had a conversation with David Goodhue, and he said to me, should I press the red button?
What did you say?
Yes.
What did you understand the red button was?
I don't know. And I should have asked him.
Give any guidance
Well,
about what the red button
he said something to the effect of, and once again, my memory's, not perfect, but something to the effect of, we have a plan ready to go. I had the impression that that there was a secondary plan that they were ready to activate. And I assumed it was because they had the wisdom to see that my plan wasn't working.
Have you ever given evidence about this? In statement form, orally, anywhere?
I object to that unless my friend wants to actually ask whether he's been asked that question by anybody ever before, including in the written statements requested by the Royal Commission, which are specific to their questioning, given that my learned friend and counsel assisting at no stage have put a request to the witness for a statement.
Mr. Buchan.
I press the question. The question is whether the witness has ever given evidence of that conversation before. I haven't progressed beyond the question. I just want to know whether he's ever given evidence about that before.
All right. Go on, Dr. Brownlee.
Thanks, Your Honour. I've only given evidence at the Royal Commission, and I don't remember being asked about it.
Right. You were the person who had proposed the model, right?
Yes.
What happened here is that Anglicare effectively accepted your advice and were prepared to act on your advice, right?
That's not the way I saw it. I did not see that I was the decision maker at any stage.
You were the advisor.
I was the advisor.
You gave advice and they accepted that advice, right?
Yes.
Now, you also then were communicating at a very high level with other government agencies about this proposed model, right?
Yes.
And as at the 17th of April, your proposal was largely accepted across the board.
Well, except that I had stood down to see if there was another plan, to see if there was a better idea.
You mean for a short while on the 16th when you were frustrated that
I was very
with the meeting in the circumstances that have been described?
I was very definite about standing down on the 16th. I needed to know if there was another plan, and I wanted people to have the opportunity to implement another plan.
Right. Well, I've put to you an alternative possibility about what happened on that occasion. We won't traverse over that ground again. But what happened in the wash-up is that ultimately you were brought back into the fray, right?
Yes.
And your plan was the one that was adopted.
Yes.
I mean, if there was going to be a decision, for example, that patients had to be hospitalised, you were the obvious person to make that decision, weren't you?
Yes, I'll accept that at that point I probably should have hospitalised patients.
I mean, when you say earlier in the evidence, I take responsibility for the decision that was made,
Yes.
right? Doesn't that responsibility also entail that if the circumstances were such that this model was no longer appropriate, it really was, you're in a very privileged position to be able to advise upon a different course being taken? You accept that?
I thought that's what I was doing.
That is by saying this isn't working.
Yes.
But did you provide any concrete suggestions about what should happen besides saying this isn't working?
I'd come off one of the worst days in my life, and I was out. There was no petrol in the tank.
You're saying you were overburdened as well.
Yes.
You had a hospital sitting 1.7 kilometres down the road, right? And you knew intimately what the level of resourcing was in that hospital, right?
Yes.
You knew if the system was overburdened, that was an option. Taking the strain off the system, moving the COVID positive patients to hospital.
It seems simple now. It didn't feel simple at the time.
Right. Is that a call that you could have made?
I made the call, I thought, to the decision maker, and I said, we need to do things differently.
Right.
And I believed I was making that call.
So that, Mr. Goodhue is not a doctor.
I don't mean I was making the call to send them to hospital.
Yeah.
What I mean is I was putting up my hand and saying,
Change course.
change course.
Right.
And I was led to believe that there was another plan which would bring a lot of resources into the equation. And that turned out to be true.
The Baptist care nurses don't come into the 24th, right?
Yes.
The evidence seems to suggest there were staffing improvements that occurred from that date and that things started to turn around from the 24th of April. Do you agree with that characterisation?
I remember it turning around from very soon after the 20th.
And how do you say that it turned around after the 20th?
The acute crisis on the 20th was due to half the staff not being there, or some percentage of the staff not being there, which was an acute Monday morning decision to furlough staff that I had no control over.
Your evidence before was that the significant turning point was when the Baptist care team came on board, which was the 24th of April, and B, when the locum GPs attended, which was the 30th. But you're now saying that you think the significant turning point was at an earlier point after this conversation on the 20th.
I don't think you can categorise it as one turning point. I think the 20th was the nadir, is your words, and I would agree with that. And so from a nadir, there is improvement immediately. And I don't know what happened on the night of the 20th, but my recollection is there were a lot more staff on the ground on the 21st than there had been on the 20th.
But Doctor, in terms of being there on the 20th, in that system under strain, seeing what you saw, knowing that there's a hospital option available, that was a call for a doctor to make, wasn't it?
Perhaps I made the wrong call. I'm sorry.
But you accept that it was a call for a doctor to make?
I didn't see it that way at that time. I felt that I was in the middle in the hierarchy of decision makers, I guess. I was certainly advising, but I didn't feel we had a command and control structure where the command overall was sitting with me.
Who was going to make the call then?
Well, David told me he was going to press the red button, and I was delighted that there was a plan, and I should have drilled into what that plan was, but he said something in the order of, I'll press the red button. It's some expression like that.
Right. If it was Anglicare doing something, pressing a button, did you understand that to mean increasing the resources that were made available to the home?
Sure, yeah.
I mean, that's the sort of decision someone at Anglicare might be able to make. Is that what you understood was going to happen?
Well, I can't entirely remember the conversation, but it was the Commonwealth being somehow involved, and I didn't know the details.
Right. But in any event, just coming back to that, and this is the last question I want to ask you, the hospital option. Is the state of the evidence that you made the wrong call about that? Is that fair? You said you may have made the wrong call. You apologise for it. I just want to understand the extent to which you're saying.
My thinking now is coloured by the time period we're in now, and I've spent this week listening to lots of academic experts who weren't there on the day, and
To be fair, they're not just academics. These some of these experts are involved in active.
I withdraw that. I'm sorry.
Clinical care.
I'm thinking, and I'm trying to express that I've actually, listened to what they've said, and
Yes.
there's a lot deeper thinking than I had on the 20th of April. And once again, it was a distressing day, and we were all tired, and it was hard to be thinking clearly and making the right decision. And maybe I made the wrong decision, and maybe I should have said, let's send them all to hospital. But once again, the concept of send them all to hospital worries me, because you are moving people who don't want to go to hospital, and that has been an equipoise position that I'm conflicted about. But in retrospect, I should have gone back to Newmarch and done a round of the positives and picked people and sent them to hospital. That's what I should have done on that day. But I was exhausted.
Other witnesses have had an opportunity to make comments, reflections about what happened. Now, in your statement, there's a very detailed section that deals with those reflections, and we have that in evidence, Doctor. Is there anything orally that you want to add?
Well, firstly, again, for the families, I spent time with your relatives, and I had the privilege of seeing them at a very vulnerable time. And my sympathies. To the people that were there with me, the nursing staff in particular, and you've heard testimony from several of them. Thank you. And I think the rest of it's in my statement.
Thank you, Doctor. They're my questions.
Thank you. Dr. Brownlee, I'm just going to inquire at this stage whether there might be any other questions for you. Ms. Davis is not here, but someone here in Ms. Davis's place?
I have no questions, Your Honour.
All right, thank you. Mr. Palfrey, just seeking indication at this stage whether you have any questions for Dr. Brownlee?
No, I don't have any questions, thank you, Your Honour.
All right, thank you. Ms. Furness, just seeking that same indication at this stage?
No questions for the witness, thank you.
All right, thank you. Ms. Richardson?
Just a couple of questions, Your
All
Honour.
right. Just before you begin, I'll just ask Mr. Ford, I know it depends on obviously what Ms. Richardson might ask, but do you anticipate having questions for Dr. Brownlee?
About 5.
I see.
They won't take long.
All right. Go on, Ms. Richardson.
Dr. Brownlee, you recall that you gave a witness statement in the Royal Commission?
Yes.
And you gave evidence at the Royal Commission?
Yes.
You had the benefit of legal advice when you prepared that witness statement?
Yes.
And you were asked the question if this could be brought up on the screen, please. It's volume 20, tab 24. I'll read out the question. Whether residents who tested positive, the question put to you was whether residents, this is on page 19 of that statement, whether residents who tested positive for COVID-19 and were treated at Newmarch received treatment comparable with what they would have received in hospital. And 172, your answer is yes. In my opinion, the residents who tested positive received treatment comparable, and you go on to give detailed reasons as to why that was. Do you recall giving that evidence?
I do.
Do you stand by that evidence?
I have modified my views after listening to my my colleagues in the last few days. It's sometimes hard to admit you're wrong.
But do you agree that that's the view you held at the time? That
Absolutely.
Just wait. At the time the outbreak was on foot, that's the view you held?
That is the view I held.
And that's the view that you communicated to staff at Newmarch House?
Yes.
And that it's difficult for me to deal with the evidence about Mr. Goodhue and red buttons in circumstances where he's not here.
Yes.
But is it, you mentioned that what you understood him to be referring to, sorry, I won't deal with that. Do you agree with me that in your witness statement to the Royal Commission, at no point in answer to the question as to whether people received comparable treatment, did you say that you had raised a concern about nursing care that was being provided through Newmarch House nurses as part of your answer?
Sorry, I'm just trying to work out what.
I'll put it in a less confusing way. You were asked whether, in the Royal Commission, whether Newmarch House residents who tested positive received equivalent treatment. That's question E that was on the screen a moment ago. Do you agree with me that at no point in answering that question did you refer to a conversation involving a red button and your concerns about the level of care that was being provided by Newmarch House in giving that answer?
I object to that. The question's very specific, and it doesn't go to the level of specificity that my learned friends try and put.
Yes, Ms. Richardson.
I think, given that Mr. Goodhue's not a witness and this is not evidence we've heard before, and Brown and Dunn doesn't apply in this jurisdiction, I'm constrained in my ability.
I didn't say it did. I'm just looking at the question that's asked.
I'm just trying to deal with the time constraints and the limitations on the evidence.
Yes, well, as I indicated earlier, you should not feel constrained by time. If there's a need to continue Dr. Brown's evidence on another day, that can be hopefully accommodated.
Okay. Do you agree with me that at no point are you able to point to any communication from you to anyone at Newmarch House discussing an alternative model to the model that you had proposed in dealing with the outbreak?
No.
Objectives. I think my friend needs to read down a few paragraphs to 132 and 133. It might not be to the level of detail that she's after, but it is addressed. No. 134, sorry.
Well, the question I'm putting is about whether there's any communication from you to a Newmarch House person about an alternative model to managing the outbreak to the one you had been, to the one you proposed. Do you agree that there's are you able to point to any communication in writing from you to Newmarch House about you considering an alternative model to the one that you had proposed and implemented at Newmarch House?
I can't remember any.
Isn't it the case that that's very unlikely that there will be such communication when your view at the time was that COVID positive patients were in fact receiving comparable treatment to what they would get in hospital? That was the view you held at the time.
That is the view I held at the time.
It's the case, isn't it, from the beginning of the outbreak that the position of the Public Health Unit and Nepean Local Health District was that all their negative residents were considered close contacts?
I would imagine so.
Those are my questions.
Thank you, Mr. Forden.
I'll be very brief. Who is Dr. Sam Ord and Dr. Stuart Lane, or who are, sorry?
They're intensive care specialists at Nepean.
And during the course of the outbreak, did you have cause to contact them in relation to seeking advice?
Yes.
Who is Dr. Lucy Morgan?
Dr. Lucy Morgan's a respiratory physician at Nepean Hospital.
And during the course of the outbreak, did you consult her for advice?
Yes.
Who is Simon Coffey?
Simon Coffey's an orthopaedic surgeon.
And during the course of the outbreak, did you have cause to seek his advice?
Yes.
There's been some evidence in this inquest about high flow oxygen.
Yes.
Was that available on the COVID ward at Nepean Hospital in March, April, May of 2020?
Not with conventional equipment, only with intensive care supplying it.
Thank you. Nothing further.
Thank you. Anything arising, Mr. Buchan?
Just one question. You were asked about whether you had consulted with an ICU, respiratory and orthopaedic specialists during the course of the outbreak.
Yes.
Were they general consultations about an approach to take, or were they in relation to particular patients?
Mixed.
Were any notes or records created?
There would have been to do with patient AF and discussion.
In other words, a survivor?
No.
Oh, okay. Someone who passed away?
Somebody who passed away.
I think you can name the patient in that context. It's Miss Fay you're talking about?
Yeah.
Yes.
Yes.
Right. And, sorry, all three of those conversations were in relation to Miss Fay, were they? ICU, respiratory,
No,
orthopaedic?
Orthopaedic, the conversation would have been recorded in survivor RJ's. And I'm not sure, survivor RJ, I think, would be recorded, that conversation. Sorry, other question?
No, that's it. I just wanted to drill down on what those conversations were.
Yeah.
All right, thank you. No further questions.
Thank you. Look, apparently that brings us to the end of your evidence. Thank you very much for attending to give evidence across a couple of days. You're now excused and you're welcome to leave the witness box. Thank you.
Thank you, Your Honour.
Your Honour, tomorrow family representatives will be making statements to the court. A 10 o'clock start should be sufficient, according to our information of the demands on the court time. We'll get through that material.
Yes.
I know the time now, so I'm not going to say anything further at the moment, but clearly we'll need to turn to the written submissions and timetabling and things of that nature. So we'll have further conversations with our colleagues this afternoon on that subject.
All right.
And then that'll be raised in court tomorrow.
All right. Thank you for that.
Thank you, Your Honour.
Thank you. I'll adjourn until 10 o'clock tomorrow morning.